Hello guys. So welcome to the second class of Farre 4th years. And today we are going to deal with orthopedics. That is, we have two important topics for the day, that is pediatric and joint disorders. Both these topics are very, very important. Okay, before that, am I audible, visible? Just a thumbs up will do. Which notes, Amir, you're talking about? The last class notes? All the notes are available in our Telegram groups. Okay. After the class, I'll just check with the tech team again today regarding your notes, okay? So let's not waste further time because we are already 10 minutes late for the class today. So let us start the class. So today, what are the topics we are going to? Yes, Amir, I'll do it. After that, you can thank me again. Okay, hi. So the topics today we are going to discuss are, the first one is the very, very important DDH, the Perthes, and the second one is CTV. So this is mainly for your long questions. So this is for long questions, and DDH can also be a long question. But usually the Perthes, osteogenesis imperfecta, these are for your short questions, right? And again, rheumatoid and osteoarthritis are two, again, long questions, right? So this is a very, very important PowerPoint or very, very important class for now, because very much these are all long questions which will score you about 10 marks for each question, right? So let us complete few short questions and then we'll go to our long section, right? So first one is osteogenesis imperfecta, right? So what is osteogenesis imperfecta? As the name suggests, you know what is osteo and genesis, right? Osteo and genesis, right? Imperfecta is nothing but it is imperfect. And what do you mean by osteo? That is bone. Genesis is formation. So there is some problem in bone formation. So if we go back to our basics, just to make you understand that bone itself is formed by two components, right? So the first one is organic and the second component is inorganic, right? Organic and inorganic. If you go back to your chemistry, you remember organic is all about carbon, right? And inorganic is your calcium and phosphorus. Similarly, here also organic is all about your collagen and inorganic is all about your calcium and phosphorus, right? So these two are very, very important. So collagen is the prime component and then it is deposited by calcium and phosphorus, which will make your bone strengthen. So this is the basis of bone. So whenever you're writing something, if you start from the basic, no, you can create the answer then and there. Instead of mugging up the answers, you can write your own, right? So here we are talking about the basics of the bone, where bone is made up of two important components. One is organic, the second one is inorganic. And here why I'm telling you in this detail, because we want to understand the importance of collagen here, because osteogenesis imperfecta is nothing but it is a disorder of bone, right, characterized by formation of weak bones, right? Weak bones. Why there are weak? Why these are weak? And how do we come to know that the patient is having this particular disease or disorder? Usually they end up with multiple fractures, bone deformity. And now I know why the question would be why they are. Yes, it is a brittle bone disease. And why it is a brittle bone disease? Because of the collagen deficiency. So collagen type 1, right? So where all you can see this collagen type 1. So first and primary, I told you it is bone, then your teeth, then your ligaments, right, and your sclera. So because of this deficiency of type 1 collagen, and what are the genes responsible for it? It is Col1A1, Col2 and A. Right? So this is what you have to write in your answer. So first you will always start with the definition, and you also know the primary, the basic behind the definition, that is bone has certain components, and because of that primary component, which is the collagen, which is deficient, and this will result in a condition which is called as osteoporosis imperfecta. Right? So this is collagen type 1, which is also present in all these particular structures, and this is due to the gene responsible. What is the gene responsible? Col1A1 and Col1A2. And still you want to gain more marks, what you can tell is this was discovered by silence. There are two types. So one is your autosomal dominant, and the second one is your autosomal recessive. Right? So this is more fatal. The recessive is more, right? You can tell that silence has developed 6 types, but what you can remember is 2 types, that is autosomal dominant and autosomal recessive. Usually this dominant one is benign, that is mild variety, and autosomal recessive is fatal, that will result in early death of that baby. Right? Is that clear? Right? Now the clinical signs and symptoms. What happens is in the clinical signs and symptoms, as we have already discussed, the patient usually has very brittle bones, and these bones, they break often. Right? They break often, and this you can see from a very young age, as the with the even with the real fall. Right? So that is what you have to remember. So first we are talking about what is the bone is made up of, then we have spoken about the definition, and then we have spoken about the pathology. The pathology mainly lies in type 1 collagen, which is deficient, and this is by 2 genes, that is called A1, that is Col1A1, Col2. Still, if you want to gain little one extra edge of marks, you can write this point. Otherwise, you can simply ignore it. Then the clinical signs and symptoms are usually the patient come with the brittle bone, that is fractures. Fractures of long bones by birth. And later on, once they start walking also, even with the trivial falls. What do you mean by trivial falls? Just minimum force, the the bones will get fractured. But what is very important here, healing is normal. Healing is normal. So you will see all types of stages of healing. If you remember, there are certain types stages of healing, right? We have discussed what is fracture healing. So in that fracture healing, there is a stage of, first is the stage of hematoma, then soft callus, hard callus, and remodeling. So if you take an x-ray of a patient of osteogenesis imperfecta, what you see is you can see all the stages in that particular x-ray, because one fracture will be healing in stage of callus, the other fracture will be healing in stage of hard callus, one will be remodeled. So that is how you can see. Because here the thing is, what you have to remember is healing is always normal, because of these soft bones, that is the bones are very soft, because there is no collagen in it, it will break easily. Right? And now what you can see is sometimes the bone deformities, because of the softness of the bone, they go into deformity. The bone is seen. And what you have to remember is the triad in case of osteogenesis imperfecta. What is the triad? So the triad is blue sclera, you have to remember, then fractures, and then what you see is otosclerosis, right? Otosclerosis, and dentigenous imperfection. So there is a problem with the teeth, with hearing, there will be hearing loss, and then you will have the blue sclera. So this is all you see. Yes, Kala, you're right. So blue sclera, generalized osteoporosis, and dentinogenesis. So okay, osteoporosis is something like where the bone again is softened there. Okay. And then how you look go for the treatment. So once you have diagnosed, because on the x-ray you see there are multiple fractures, and usually most common diagnosis we put for these people young age group, and with the blue sclera, with otosclerosis, that is hearing loss, and dentigenous imperfecta, we put the diagnosis as osteogenesis imperfecta, right? And then how do you treat it? So treatment, usually we can go with bisphosphonates for medical treatment, and usually the treatment would be surgical if there are multiple fractures in walking age. Otherwise, usually in pediatrics, what happens is the fracture heal by themselves, right? Usually if it is a very young or a newborn having fractures, we generally splint it, right? They heal by splinting. But once they come to the walking age, you have to treat with two important surgeries. You have to remember, one is your dual rod, where it grows. There's a growing rod, what you can remember, right? It increases its length, and then sheikh kebab surgery. This is very important. What is sheikh kebab surgery? Here what happens is, if there are multiple fractures of bone pieces like this, they will pass one implant through all the bones, the implant. So if you see, if you go to a restaurant and if you order the kebabs, or if you go to the barbecue nation, right, you can see that all the pieces, the chicken or the fish pieces, that they are put to rod. So that is called the sheikh kebab surgery. And this dual rod is, it is put intramedullary, but it increases in size, or it increases in length as we are putting this in the pediatric age group. And now usually they ask you, what are the differential diagnosis for osteogenesis imperfecta? What you have to remember is, one is this child abuse. So this area of child abuse, where people again come with fractures even, and they don't give you proper history. So that is one of the thing where you have to be very careful to differentiate between osteogenesis imperfecta and child abuse, right? And what would be the complications? The complications are here mainly the deformities, as we have discussed. And if it is autosomal recessive, it is very severe, and patient may die by the age of 10 or 11, or sometimes they may end up with stillbirth, right? So this is about osteogenesis imperfecta, right? Is that clear? Any doubt? Here you can also try orthotics. That is some splints which also can be tried for the patient with osteogenesis imperfecta. Right, so this is about osteogenesis imperfecta. This is what you write. This is a short answer, right? So this much would be more than sufficient. So you always start with the definition, then you write the pathology related to it, then the clinical signs and symptoms, and then how do you treat it, and differential diagnosis with the right? Is that clear? So this is child abuse is nothing but your battered baby syndrome, right? And one more thing is, how do you diagnose it prenatally? So what they do is chorionic villus sampling they do, and then they do diagnose it prenatal. right? Ashutosh Kumar Moria, hello. Kalai, hello. Guys, is that fine? Any doubts in osteogenesis imperfecta? You want me to repeat something? Mansur Alam, good morning. Yeah, okay, right. So this is what you have to remember. That would be more than sufficient for osteogenesis imperfecta. And next, one more short question, what we are going to discuss is achondroplasia. So this is also very easy one, but usually at your level, not required in a great detail. But for a short notes, it could be an important question, right? So what is achondroplasia? Again, going with the definition and the basic achondroplasia. What do you mean by any achondroplasia? A means always absence, right? Or not there. So chondro means again cartilage, right? So here what is actually happening is there is absence of endochondral ossification, especially in the long bones. So mainly your arms and legs are, I mean, not that way. I mean, I wanted to tell you that your limbs are affected, mainly your upper limb and the lower limb are affected. So that is what I wanted to tell. So how do you write the achondroplasia answer? So this is the basic you want to put in your mind, that there would be absence of endochondral ossifications. So in the above question, osteogenesis imperfecta, because we have read about fracture healing before, that question has become easy for us. Now you can understand what is a fracture and what is a healing process and all, right? Now we already know what is an endochondral ossification, because again in the last class we have learned how a bone is healed through cartilage intermediate, right? So similarly in this, what happens is usually as we grow, as we age, there will be endochondral ossification which is happening in the body. That is the growth of the length by the epiphysis there. So because of that, because of the growth plate, there would be no proper growth in the long bones, especially upper limb and lower limb. Yes, very good, Kala. It is rhizomelic dwarfism. What do you mean by rhizomelic dwarfism? Yes, definition. Okay, I'll tell you in few seconds. So first, let us complete the definition. So this is a condition. So achondroplasia, a condition in which defective endochondral ossification occur, and especially if you remember, it is in the limbs, right? And as Kalai has mentioned, it is autosomal dominant, and if you want to again go for extra edge, it is FGFR3 gene mutation. So fibroblast growth factor gene mutation. So because of this mutation, what happened is this was called a dwarfism. So what happens is the trunk is normal, and there will be problem mainly in the proximal part of limb compared to the distal part. That means, example, your humerus will be short compared to forearms. That is the definition of rhizomelic dwarfism. Rhizomelic dwarfism. Is that clear? Yeah, it is the most common cause of disproportionate dwarfism, as we all understood that from here, because of the gene mutation. One is gene mutation, that is FGFR3 gene mutation, and in that, because of that mutation, there will be problem in the ossification centers, and this because of the ossification centers, the long bones are not formed properly. They are not increased in the length as much as it is required. And then what happens, and most important thing is the rhizomelic dwarfism, where the proximal part of the limb appears to be smaller compared to the distal part, and this is most common example of dwarfism, that is disproportionate dwarfism. Clear? So that is the pathology. That is again because of the genetics which are involved here, right? And we have already dealt with what is rhizomelic dwarfism. So you can also put this as disproportionate dwarfism, right? Right. And then what would be the clinical signs and symptoms? As you know, the height is not normal and it is decreased, and it is almost 7 to 8 standard deviations less compared to the normal population, right? But what you can see is the head is big, right? And the frontal bossing, I mean, big, matlab it is normal in size. The head is big, vault is big, the frontal bossing you can see. But what is the most important thing? You can see a starfish or a trident hand, right? A starfish or a trident hand. There is a sufficient gap between your middle and the ring finger. So this is called a trident hand or a starfish, right? And again, if you see, the trunk is normal, as we have already discussed, right? And the limbs are shorter. And usually these patients might end up with spinal stenosis, is one of the most common complaint they will have. And one more thing is thoracokyphus, right? So in this, what you treat is usually lumbar stenosis. You go for a conservative treatment, observation, and if it is severe, then you go for surgery. And for thoracokyphosis, again, you can go for orthotics, I mean the braces, right? And strengthening exercise. And not to forget that the intelligence is normal. Intelligence of these people is right. So this is one of the most, yeah, you can have a few important things like, yeah, as Kalai mentioned, it could be a champagne glass appearance in case of your pelvic, and a bullet vertebrae. So pelvis will be the champagne glass appearance. So something like this, right? And the bullet shaped vertebrae. So this is mainly important for your PG, right? So this is the bullet shaped vertebrae, right? Yeah, intelligence, everything is normal as we have mentioned. Okay, so this is what still here, if you write, I mean, this is would be very much sufficient. Mentioning of these two important points in case of radiology could give you that extra edge of mark, right? So what they usually look for is, first they will look for the definition, like what actually would be the problem. And then they will look for the word dwarfism and the rhizomelic dwarfism, right? So these two are the important words which should have been mentioned. And then you have to write about this. Intelligence is normal and the trunk is normal. And what could be the most important complication? That could spinal stenosis and thoracic, right? And treatment would all mainly be because of that problem of spinal. kyphosis and thoracokyphosis. And most important thing, that is two important radiological features which you can remember, is your champagne glass appearance, and then the bullet shaped vertebrae can be observed in case of achondroplasia, right? That is what is required for this short question. Is that clear, everybody? So we are done with the two important short questions. Are we good? Any doubts? Any doubts? Moving on to the next question. So from here on, it is all long questions. Very, very important. Even if you have slept for this time of class, please kindly wake up and be alert, because from here we are going to deal with all the LQs. That is long questions. Okay. Okay, can I proceed? Alam, Ashutosh Kumar. Okay, NEET aspirant. Okay, what one tip which can give? You can join our NEET Sankalp batch. We are very, very active on the Telegram. There is a Telegram group called NEET Sankalp and INI-CET. So you can actually follow that group, and there is a personal mentoring by Dr. Rishabh and Dr. Oshika. So those two are INI-CET alumni. So I think that would be a great thing for you to join. Yeah, Piyush and Kalai, thanks for that. So from now, we are going to deal with the most important topics, right? Okay. So this is the first one. What we are going to study or read about is your developmental dysplasia of. So initially, it was the condition which was called as CDH, that is congenital dysplasia. But now the terminology has changed to developmental dysplasia of it. But why am I concerned, and why am I telling you that previously it was congenital and now it is developmental? Because there is a small reason for it. The reason is, initially when they thought the congenital dysplasia of hip, they always thought this was because of some birth anomaly. They always thought it was a birth anomaly. That means it is usually seen at a birth. But later, what they have researched, or what they have came to know, is this can even occur in the growing age group. Growing age group. So there is a, and this can be a spectrum of disease. This can be a spectrum of disease where the child can directly be born with a displaced hip, or it could be a subluxated hip, or it could be a normal hip but can lead to dislocation later. So putting all this spectrum into one thing, they have named this as a DD, that is developmental dysplasia. That means, what I want you all to understand from this point is, it is not always the newborns we check, and if we see that Barlow and Ottolini is there and that screening is done, and if there is a slightest of doubt of some subluxation is present in that particular area, you have to keep following the babies. You have to keep following, because this is the spectrum. Even you can see it after 3 or 4 years also, right? So that is why I want to just give you a brief introduction of that. And now let us start with the definition. So definition is nothing but, this is a condition. So developmental dysplasia is a condition in which hips can be involved with spectrum such as So the spectrum would be normal, birth, later, can easily dislocate, or subluxated hip, or directly the baby can be born with a dislocated hip. Right, so this is all the definition of the developmental dysplasia. So developmental, there is a problem in the development of the baby hips, and this might lead to a condition called dysplasia. That means some abnormality in the acetabulum, or some abnormality in the femoral head, which is resulting in a grievous condition, which this may lead to a dislocation of hip. So what we are more concerned is our hips, I mean the baby's hips getting dislocated, right? So what is the pathology there? So why it is actually happening? So this could be a reason of tabulum not formed properly, not properly during the birth. During birth, there is some problem in the acetabulum which is not formed properly. And there could be various other reasons also. So some genetic factors which can lead to your ligamentous laxity, right? Or they could be weakness of the muscles, right? So there are certain these are spectrum of, again, some pathological condition involved in this formation of DDH, right? So what is the incidence where we actually see this? We see 1 in 1,000 live births. 1 in 1,000 live births, you can see that the baby is having DDH. And what are the causes? Again, the causes would be, I have told you. So the first one is usually the ligamentous laxity. And why this ligamentous laxity? Because of this progesterone hormone, which is released in pregnancy. So this could be one of the cause. The progesterone hormone could be one of the cause, or the breech position of the baby. Crowding, the breech position of the baby could be one of the cause, right? And sometimes the swaddling of newborns, usually this is practiced in Western countries. You know what is swaddling? So what they do is they put the baby in a cloth. So first they'll put the cloth on the uh, couch or the bed, and then they put the baby. So the baby legs are something like this, straight. So baby legs are straight, and they swaddle it, and they will put the cloth over it. I mean, so the baby's legs will be exactly straight like this, right? And over that they will tie this cloth. So because of that adduction, what they're doing, this might result in hip dislocation, right? So these are some of the causes which they have come to know. And on the contrary, in the Asian countries, if you observe, we don't have this practice of swaddling. What we have, we will put the baby on the hip, right? Baby on the hip. And what will this do? This will abduct the hips, right? So if you see, we have this habit of holding the baby like this, and if the baby wants us, you want to carry the baby, you will put it on the hip. Usually the mothers in the Asian countries, I mean, you can ask actually your mother, she would tell you that we were carrying you on the hip like this, and then she will do all the work which is required to do. So this abduction, usually what causes this, will place the head of the femur exactly into the acetabulum socket. So once this head is completely placed in acetabulum, now the development will be in such a way that this will prevent the dislocation. But when you do this swaddling, now you put this limbs in adduction. So the femoral head is not exactly sitting into the acetabulum, and this will lead to DDH, or dislocated hip. Right? So this is not advised usually, and this is advised. Put the babies on the hip so that the hip is nicely abducted, and the femoral head will nicely see right? Is that clear? So why I'm telling you in this detail is you have to remember what is actually the pathology happening so that you can write the answer in a great detail. You know, once you understand why it is happening, then you can only put everything, right? So you can also put what is the definition, what is the pathology, and then you can write what are the causes of this, right? And then risk factors. Risk factors, as we told, female baby breech position is one of the risk factor, and firstborn, right? So these are all the risk factors for the baby. If the baby is a firstborn female in breech position, then you have to examine or screen the baby for your DDH, right? So how do you screen it? How do you screen? How do you and previous DDH baby? If previous you have a DDH baby, then again there is every chance that this baby can also end up in DDH. That is an oligohydramnios. So these are all the risk factors. So whenever you see lurching for what? If the baby starts walking, I mean, this lurch you can see in the later stages, not immediately, but as the baby grows, no, maybe when she becomes little teenage, then you can see this lurch. That is called the Trendelenburg gait. Okay, so for now it is the female, the breech position, the firstborn, and oligohydramnios. This is one of the most important risk factors, right, for the DDH. And how do you screen? So there are two important tests for screening of the DDH. So what are those two important tests? Yes, Kalai, what are the two important screening tests for DDH? So one is your Barlow, second one is Otterlani. Yes, yes, very good. So Otterlanis and Barlows. Otterlonis and Barlows. Very good. So I was about to tell you the same mnemonic. So Barlows, remember it as bad test. It is a bad one. So obviously this will become good, right? So one is bad, the other one has to become good. So what is bad in it? So whenever you're doing a Barlow's test, what you do is you do adduction. Adduction means what you're doing, you're swaddling. That is, you're bringing or you're causing dislocation, right? And when it comes to Otterloni, what you're doing abduction. You're doing abduction. That means what you're doing is you're reducing it. Actually, you're doing reduction, right? So this is what you have to remember. This is very, very important. Try remembering only this particular picture, right? That's fine. So this is have to print in your mind. So whenever you're talking about screening test, whenever you're answering any DDH question, what you have to remember is there are two important screening tests. What you have to remember, one is Barlow's and second one is Otterlani. And whenever we say Barlow, it is a bad one. Bad one means it is doing adduction, because BAD, adduction, and this adduction will make the hip dislocated. That means what will happen? You're taking a screening, that is, you're taking a newborn baby. So this baby is a firstborn, it's a female baby, it is a breech position baby with oligohydramnios. So all the risk factors are there. So you are assuming that this might land up in DDH, right? So what you do, you first see the hips. And if you see the hips, and if the hips are normal, what you have to do is now you try to dislocate it, so that you have to see the ease of the dislocation. Now what you do, you adduct, so that what happens, you're on adduction, you're bringing the both femoral heads outside. Adduction means you're dislocating the hips, and on dislocation, if you hear that clunk sound, that means this is the case of DDH. That means the hips are dislocatable. That means the femoral heads can be brought outside with this maneuver. And you will not leave it like that, right? Now what you do again, this adduction maneuver, you will reverse it. That means you do the abduction. So once you do adduction, then you do abduction. On doing abduction, if you're putting back the femoral heads into the acetabulum, that means you have reduced the femoral heads. That is the reduction. So when are you able, again you will hear a clunk sound. So when you're able to make these two sounds, on adduction and abduction, that means this is a case of DDH. So these hips are very, very flexible. I mean, there is some problem. They are very lax. So they might result in DDH. So why are you very worried about why this DDH? So this DDH can lead to further abnormalities, right? Let's discuss that further abnormalities. Before that, what could be the associated condition? So once you have done the screening test and now you have come to know that DDH is there in these babies. So you should also look for associated conditions, like you have to again look for CTV. This can be associated. This can be associated with metatarsus adductus. So or the metatarsals will be into adduction. So there could be a condition of metatarsus which can be associated with this. So there can be a CT, congenital talipes varus can be associated with this. And sometimes the spina bifida. So all other congenital anomalies you have to check for. So these are some of the important associated conditions which you have to look for. So this completes the uh, definition, the pathology, the incidence, what could be the causes, and the risk factors, the screening test, and associated conditions. Right? And now let us see the clinical signs and symptoms. So once you are done with your screening test, you're done with the screening test, and you have heard this on the newborns. So newborns, what you do? You just do the screening test, right? And then after it is confirmed, you confirm it by ultrasound. Okay? And now, then if these babies are missed at the newborns, then if they come at walking age, so what you can see? You can see in case of unilateral DDH. So this DDH can be unilateral or bilateral, right? So in unilateral DDH, what you can see is increased thigh folds. Thigh folds are increased. Okay. And then there is a sign which is called as Galeazzi's sign. So what is Galeazzi sign? So now you do this test. So this is the Galeazzi sign, right? And you can see this dip. Yeah, this is Galeazzi sign or Galeazzi test. What you do, you flex both the knees. And now you can notice the shortening the femur, right? So because of that, the knee are not at the same level. Dip in the level. So this is your Galeazzi's test. So this is your Galeazzi's test. Understood? So this is in the walking age. When this child in after 1 year of age, then this could be your Galeazzi's sign, right? Galeazzi's sign or Galeazzi's test, right? So there will be increased thigh folds, Galeazzi sign, and one more important thing is telescopy test positive and Trendelenburg gait, or as we have asked, right? So that is the lurching. So lurching or the Trendelenburg gait can be seen. Why this is all seen? Why this is all seen? So this walking age, you see this Galeazzi sign positive, telescopy test positive, Trendelenburg gait positive, right? So this is all because of this. So if you go back to the pathology here, what happens is whenever the patient now becomes a walking age, what happens is there are certain changes which are occurring in acetabulum and femur. Acetabulum and femur. So what are the changes which you expect? So first, the acetabulum will become shallow. So what is happening? See, once the baby, yeah, vascular sign of Narath is again a sign of dislocated hip. So once the baby is coming to the walking age, neglected DDH, what happens is the head is not sitting into the acetabulum. The head has come out. So there is nothing to develop in the acetabulum. Now what happens? The depth of the acetabulum, which the depth has to be maintained with the femoral head. As the head has come outside, the acetabulum will become shallow. So there will be a shallow acetabulum, right? And then there will be proximal migration of the femur. Proximal migration of the femur. So because of that, you see there is a shortening. Because of the proximal migration, you will see there will be shortening. And then because of this, head is not seen inside, the telescopic test is positive. So usually whenever there is a dislocation hip, what you can do is, because the head is not sitting into the acetabulum like this, if you move the femur, you can easily feel the movement of the femur outside the acetabulum and into the acetabulum like this. That is called the telescoping. And vascular sign of Narath is again the pulsations are felt against the femoral head. So usually if you feel the radial pulsations here, it is over the radius, the bone of the radius or the scapula. So again, for feeling of that pulse, it should rest on a bony surface. So because of the femoral head has been dislocated, now you can't feel the femoral pulsation. That is vascular sign of positive, right? So this is all the signs are because of the dislocation of the hip. And this is outside. From outside you will see all these things such as increased thigh folds, Galeazzi sign, telescopy test, and Trendelenburg gait, that is lurch. And on inside what happens is the acetabulum is not developed, it is shallow. Then there will be proximal migration of the femur, then there will be break in the Shenton's line, Shenton's arch, right? And the femoral head will be absent or deformed femoral head, you can see. So this is the x-ray. So this is all you put in your mind, right? Before taking an x-ray, what you see is you put all this in your head, like what is happening, what could be the x-ray visualization. So once you see this x-ray, you are pretty much sure that there is no femoral head. So you cannot identify the femoral head, and you see this shallow acetabulum. So here if you see, there is a deep acetabulum, and the shallow acetabulum has become shallow here. And if you see, the GT is here and here the GT is here. So that is called the proximal migration of the femur. So this, the shallow acetabulum, the proximal migration of the femur, and the Shenton's arch. The Shenton's arch is something like this, right? So it has to go from this to this. So here it would be broken. So it would be broken. So there will be a broken Shenton's arch. What is Shenton's arch? So it is a radiological sign, right? The inferior line of the superior pubic rami will follow the femoral neck like this. So this is the Shenton's arc or the Shenton's line, right? So this will be broken in case of your DDH. So these are all the features which you see. And there are three important lines. So even on the x-rays, so when will you take the x-ray? So usually after 1 year we take the x-ray. So before 1 year, why we are not taking the x-ray before 1 year? Because the femoral head is not seen. So there is no point in taking out the x-ray. So what will help before 1 year? You have to go for ultrasound. On the ultrasound, you will identify the head, and there are two important angles, alpha angle and beta angle. It should be more than 60 degrees. This should be less than 55 degrees, right? This is the normal values. If it is reverse, then that is resulting in DDH. So this is before 1 year of age, because before 1 year of age, you don't see the femoral head. Hence, you go for ultrasound. You have to remember this. This is also a screening modality. A screening modality for DDH. Fine. And then you go for x-ray after 1 year, and the x-ray, what you see, again you see there is no acetabulum, that is your acetabulum is shallow and broke, or there is a break in Shenton's arc, right? And then you will see proximal migration of femur. And now you can draw certain lines on the x-rays to tell that the head is not in its position. Okay, so the first one is your Hillingren's line. So you can see here the Hillingren's or the H line. So this is a horizontal, H for horizontal, which is drawn along the which structure? It is drawn along the triradiate cartilage. So what do you mean by triradiate cartilage? Yes? Yeah, what do you mean by triradiate cartilage? Triradiate cartilage is a point where all your three structures of the pelvis, that is your iliac, ischium, and the Priyanka Rajput, good evening. So this is the point where the three cartilages meet. So there is ilium, and pubis, right? In the pelvis bone, there are three cartilages. So these three cartilages will meet here in this point. So this is the point where these three meet. So ilium, ischium, and pubis. So now you are going to draw a horizontal line through this through this triradiate cartilage. So this is the horizontal line. And one more, from the lateral border of the acetabulum, you draw a vertical line. So that is your Perkins. So lateral acetabulum, right? So this is a vertical. H for horizontal, P for vertical. So when you draw a horizontal line and a vertical line like this, you see you will divide this into four quadrants. You divide the area of femoral head where it should be placed into four quadrants, right? So now, as Kalai has also already mentioned, whenever you see a normal hip, what you see is the inner and lower. Inner and lower is your place of femoral head. So this is normal. But whenever you see upper and outer quadrant, this is right. So this is DDH. So here it is usually here, right? So this is your normal. Okay, let me put with the same color. So this is your normal. So this is dividing into four quadrants. So this is your outer quadrant, upper, lower. These two are inner. So whenever you see a inner lower quadrant, your head in the inner and the lower quadrant, that means at this particular area you're seeing the head. So this is nothing but a normal hip. If instead of seeing here, if you see something here, then this is a DDH. Upper outer is DDH, inner lower is. Yeah, actually, Piyush, what is the thing is, this has been all obsolete now. So we directly go for an MRI. So if you're seeing a baby, nowadays, if you see a baby of DDH, the investigation of its choice would be an MRI only, right? So this is all theoretical part, this is now we don't take an X-ray and we don't draw lines and we don't see all this. This is all theory. But practically what we do is we see the age of the patient. What we do is we see the age of the patient and then we decide. Okay. So usually X-ray is taken. X-ray is taken if the patient comes after 1 year, and we will see the position, and immediately we go for an MRI. So investigation of choice is always an MRI. That's a very good question. Okay. So this is all theoretical part. When you take an X-ray, you see so and so factors. And once the X-ray is always the basis for us, right? Whenever we see a case in OPD, we always first go for X-ray, then we go for an MRI. But MRI is very, very important for further management of the case. Right? So this is our theoretical part. So whenever they ask you about this question of, DDH, sometimes they can just put a short question like this. So they can just ask you the radiology of DDH. Then you have to start right from before 1 year of age, when the femoral head is not seen. Then you will write ultrasound. Then after 1 year, you will write so and so, and then these. So this could be a very important short question too. That is why I have discussed this in detail. Okay, is that clear? Then next, now if you see, if the patient has come to you at the age of, like immediate newborn, and you have done screening, right? and then you have confirmed it as DDH. And now what do? You will put her in a splint, that is Pavlik Harness splint or von Rosen splint. So these two are splints which are used for the babies. And now you have to tell me what would be or what could be the position of this Pavlik Harness or von Rosen splint without looking at the splint. Now everything is there in your mind, right? What is GDH? You know why it has actually occurred and what could be the causes for it. Now what you want to, how you want to treat the patient, putting everything aside, it is not surgical or conservative, but what is actually the treatment, what could actually be the treatment of this particular patient who is suffering from DDH? Yes, I want the answers. Yes, very good. So everything, whatever you want to do for DDH is chest abduction. You have to do abduction of the thighs. You have to do abduction so that now the head will sit into the acetabulum. Our main primary goal or aim is to prevent adduction, put this in abduction. So again, this Pavlik harness is nothing but, now you see, now the baby is put in abduction. This is nothing but your Pavlik harness, right? And this will have straps. Now this is flexed, the knees are flexed, so it has a shoulder strap, it has a pelvic strap like this, and now because of that two straps which are attached, it puts the baby into abduction. So this is the base, this you have to remember. And now if you understand this, it will become a cakewalk for you. Okay, and now you can put this as splint, or sometimes you can even put the cast. So that cast, it is called as the bachelor's cast, right? So what do you do? Okay, it is sounding like a frog, so okay, you can take this also. So here what you do is, now you can put the cast something like this, and then you put a bar between it. So whatever you do, it is like the abducting. It is called the bachelor's cast, right? So that is the treatment for the newborn if the baby has come to you, right? Just in newborn. Then if it is come to you in less than 6 months, still you can go for Pavlik harness. So any baby coming to you and now you have diagnosed it as DDH, the treatment of choice would be Pavlik harness or von Rosen splint, or your cast, which you can put the limbs into abduction and which will prevent adduction. So that is it, right? So this is the importance of knowing the splint. Okay, this is the photographic memory, and this would be your IBQ in NEET exam. Now they will put this, identify the splint. You can identify it as Pavlik harness, or where is this splint used. So it is used in DDH, or what is the mechanism of the splint. Will it put the limbs in adduction or abduction? So then the answer would be the limbs are put in abduction, right? They are put in abduction. So whenever you put the femoral heads into abduction, they will nicely sit into the acetabulum, so that now the acetabulum will develop into depth. So there will not be any shallow acetabulum and there will not be any proximal migration, so that the patient will have normal hips, right? Anta? Yeah, this is the picture which you want me to show. So this is the Pavlik heart. So when will you use this Pavlik harness? You can see something there, Saltus osteotomy. I'll teach you, don't worry. So this is Pavlik harness. So whenever the baby is less than 6 months, then you go for this. Okay. And now what you have to do is 1 year. So if the baby is less than 1 year, okay. So now because after 6 months, what happens is now they come with dislocated hips. Now the hip will not sit in the acetabulum, and on the X-ray you see there is a dislocated hip, right? If it is usually more than 1 year or 6 months to 1 year also. right? So dislocated hip. So what you do? So this dislocated hip has to be reduced, right? So the treatment of any dislocation is reduction. So this reduction is of two types. So what is the two types? One is your closed reduction. The second one is your open reduction. Open reduction. So when you do what? So first you try closed or open? Yes, quickly answers. Which one you will try first, closed or open? Yes, very good. Always, 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 any reduction, you have to always try the closed first. So why I'm asking this question? Because it might appear a very, basic question for you, but few people doesn't know the difference of closed and open. Closed is you don't open that particular thing. I mean, don't go to the hip joint. You just try the maneuvers from the outside and reduce. When you fail closed reduction, then you go for open reduction. Open meaning you cut open the joint and then you reduce, right? So after 6 months to 1 year, you will try to reduce the hip. So first you will go for closed reduction. If it is failed, then you go for open reduction, that is OR, right? So this is OR, open reduction. And if the baby is more age, that for example, if it is like 5 years, 6 years, then you also have to do what are called as osteotomies. So osteotomies has to be done, right? So why you think the close reduction will fail? So reasons for failed reduction, what do you think the reasons could be? Okay. So reasons could be, one is this is not very much required for you, but you can put this in your mind, inverted limbus or some soft tissue obstruction or ligaments are very, very lax. I'll write it again. So whenever the muscles or ligaments are very, very lax, even if you reduce, no, again they will dislocate. So these are all improper technique, okay. So that is actually okay. Whenever they're doing this DDH, no, usually they are all good doctors only, not, yeah, this could be a reason. Improper technique could be a reason, but it is not first three or four reasons. Improper technique could be a last reason, okay. So my idea is not to tell you the fault of improper techniques, but you tell the faults of the soft tissue. Here the soft tissue will not allow you to reduce the hip. So that is why we go for open reduction. So that is why you have to go for an MRI before attempting the reduction. So this is the MRI which we do, so that you will see what is the position of the acetabulum, what is the position, are there muscles, tendons, were they contracted or they normal, right? So then you can decide which technique you can go. And now see, here what I want to tell you is, once the closed reduction is done, I mean, if you're successful in reducing it closely, what you have to do? You have to go for hip spica. That is maintenance. Right? Maintenance. And now when you go for osteotomies, so if the patient is again more than 3 years, then you can go for osteotomy. So what do you mean by osteotomy? What do you mean by osteotomy? Tomy is, what is anatomy? Meaning of anatomy? Yes. What is the meaning of anatomy? Yeah, tomy is opening, cut. What is ana? Ana is, okay. Similarly, tomy here is cutting. Osteo means bone. So here we use a specific instrument such as osteotome. Various osteotomes are available, the straight osteotomes, the curved osteotomes, and then we do this technique which is called as osteotomy. So here I want you to gain more marks than everybody in the class. So whenever they ask you a question of DDH and you have happened to write all the things correctly, just mention the names of this osteotomy. Okay, no need to write the procedure also, just remember. So these osteotomies can be of two types, right? So this could be a femur or a acetabulum or a pelvic, right? So here what happens is the hip joint, of course it is very painful. Painful, I mean, we do it under anesthesia only, no? This is a major surgery. This is a major surgical procedure where, this osteotomies are mainly done for correcting the deformities. So whenever you see the bone is not aligned properly, or if you want to change the angles of the bone, then we go for this osteotomy. If you remember, the supracondylar fracture will result in a cubitus varus. So if you want to treat the varus, you go for osteotomy. So what you do, you correct the angle between the like two fragments of the bones, right? So similarly here what we do is we cut open and then we cut the bone. So here in Salter's osteotomy or Cherry's osteotomy or Pemberton's osteotomy, what we do is we cut the acetabulum, that is the pelvic bone, acetabulum or the pelvic bone. So here in Saltus, what we are doing, we are cutting the iliac bone. We are removing a wedge-shaped iliac bone so that you will put the acetabulum nicely over the femoral head. And Charis osteotomy, you're just shifting the position again. You're giving a transverse cut in the ilium like this, and then you're shifting the position so that this medial side of the acetabulum is covered properly, right? So this is Charis osteotomy. This is a curved osteotomy. Pemberton's is a curved osteotomy. Again, you're doing it in the iliac bone. So what you're doing is you're giving again a curved surface for the acetabulum. Curved surface of the acetabulum so that the femoral head nicely will sit into it. So all this is again done for the femoral head to come and sit into the acetabulum. Because as the patient will reach 3 years of age, what we have learned, the acetabulum will become shallow, right? So the femoral head, even if it is round and nice, it can nicely sit into the acetabulum. So for covering this femoral head nicely so that henceforth the growth after 3 years will be good, you have to prepare that acetabulum. So you have to increase the depth of the acetabulum, making it a round structure like this so that you can accommodate the femoral head, right? So for that, remember there are salters, there is Cherries, and there is Pemberton, and nobody is going to ask you what is Salter, what is Cherry, what is Pemberton. No, nobody will going to ask you. They will just ask you when is osteotomy preferred. Then you will write whenever a closed reduction is required and feel that acetabulum is not adequate. Then you go for osteotomy. Usually that is seen after 3 years. Okay, procedure. Which procedure? Usually you see this after 3 years, the osteotomy is helpful. I am not telling you any procedures here. I'm just explaining you. So whenever you want to conclude the question, you are writing the treatment. So you will write less than, okay, let me complete this, then I'll again repeat. So now we are completed this acetabulum osteotomy. So there is also osteotomy for the femur. when the femur is like you have to do more of abduction to bring it into the acetabulum, then you can go for varus osteotomy of the femur. Okay. So pelvic we have certain osteotomies, and varus, this is for femur osteotomy. Right. So Samantha want me to repeat it. So here this is an osteotomy. What is osteotomy? Osteotomy is cutting opening of the bone. So you will cut the bone so that whatever the bone, if the bone has to be straight like this. No, in malunion it gets deformed. So to correct the alignment of the bone, you cut a part of it. I mean a wedge of it, and then you correct it. Right. Similarly, in DDH also, you can treat the pelvic osteotomies. You can treat with certain pelvic osteotomy, right? So in that, the first one, what you have to remember is Salter osteotomy. The second one is Charis, and third one is Pemberton. Nobody is going to ask you any procedure is here. No procedures are asked in the exam, or they don't expect you to tell the procedure also. What they want to listen from you all is what is an osteotomy. So what is an osteotomy? To correct any deformities, right? So that is the osteotomy. You will correct the deformity with it. And now what is the main aim for us in DDH? The head has to be nicely sitting into the acetabulum. Now here the head is like this. The acetabulum has become shallow like this. This is a dislocated hip. Now you're trying to reduce and put it inside, but because of the acetabulum is so shallow, it is not making the head nicely to sit. Again, it is dislocating. The head is getting dislocated. Now what you do certain osteotomies like the Salter's osteotomy. The Salter osteotomy is done in the iliac bone. Iliac bone, you do this Salter osteotomy. It is a wedge shaped osteotomy, right? And now what you do, once you remove this wedge, this nicely covers the femoral head. This acetabulum will become deep, and it will nicely cover the acetabulum. In Charis osteotomy, what you do, you just give a transverse slit in the ilium bone just above the acetabulum, so that again you can nicely cover it. So this, which osteotomy to be done, will be decided based upon the patient's condition, right? In Pemberton's, it is a curved osteotomy. In Pemberton's, it is a curved osteotomy. Again, you curve it, the acetabulum is curved like this, so that the femoral head is completely engaged in the acetabulum socket. So this shallow acetabulum, you are making it deep. So this femoral head goes inside. So one is a wedge shaped, one is a straight, one is a curve. This much, if you remember, it is more than enough. Is that clear, Samantha? So this is about your pelvic osteotomy. So there are varus osteotomy also there for your femur, right? So for femur, one osteotomy if you want to name, so that is your varus osteotomy. So for pelvic, we have three: Charis, Salters, and Pembertons. And for femur, we have varus osteotomy. Why? Procedures, is that clear for you? Okay, varus is again, so if this is your femur, yeah, if this is your femur, right, what you have to do now, this femur is in adduction in a dislocated hip, right? Dislocated hip. Now what you do, you have to abduct it so that it will sit into the acetabulum. So sometimes what happens is we have to go excessive abduction, which is not possible. So instead of going excessive abduction, again we'll make a cut and we will make femur into varus, so that with minimum abduction we can put again into the acetabulum socket. So this much if you remember, it is okay. So femur is like this. Now you make it little varus, so that because instead of going like this into abduction, because of that small varus, it will come and sit into your acetabulum. So what you have to remember is this varus osteotomy is done in the femur, whereas the pelvic, the Charis, Salters, and Pembertons are done in pelvic. So these are the osteotomies which are required for your DH. Is that clear? Varus is also type of osteotomy. So you have two types: varus osteotomy, valgus osteotomy, right? So here what we use is the varus osteotomy. Okay, so now that here, now what you can remember is, and finally, if nothing is working out and the patient has now entered into 12 years and 13 years, so what is the treatment? So you can't go for your osteotomies. So directly you go for the total hip replace, right? So whenever the patient is entering into teens, you have to remember that the treatment of choice EDH would be total hip replacement. Is that fine, guys? So this is the table, which is very, 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 very important. So you know everything background, but you have to put it in a presentable way in the exam. So this table has to be written the exam. So here there is nothing to mug up. We already know if it is less than 6 months, you go for Paediatric Orthopaedics, that is the splint. And if it is 6 to 18 months, that is less than 1 year from after 6 months, you try for closed reduction first. And then if reduction is successful, you go for hip spica. What is spica? 1.5. So this is the baby. What is hip spica? So this is the baby. So this whole limb, you put it in the cast and then with the abdomen. So whenever you're taking help of abdomen plus limb, that is called, sometimes they also put up to this half. Okay, half of this limb is also included. So this is called spica. So this hip spica is very, very important for the maintenance. So once you have reduced it closely, you have to maintain it in the hip spica, right? And after 18 months to 3 years, or if your close reduction is failed, what you do, you go for open reduction, you cut open, you will find all these faults. So if it could be inverted limbus, or if there's some soft tissue obstruction, if there is some ligament which is not to reduce it, or if it is there is some problem in the muscle, so you will tackle all those problems and then you will do a close open reduction and again put the patient in hip spica. And after 3 years, if the patient is after 3 years, you again go open reduction or osteotomies. And now it is neglected into the teenage group, then the treatment would be THR, that is total hip replacement. Is that clear? DDH? Where has Kalai gone? Kalai? Here, everybody? So this is what you have to write for your DDH. So first, starting from the definition. So this is the definition. You remember what could be the pathology. Then remember the risk factors, which is very, very important. Female, breech, firstborn, oligohydramnios. And then you have two important tests. This is very, very important. So two important tests. One is your Barlow's, Atalanes, and associated conditions. You can name few, and then clinical signs and symptoms. These two are important. What the your examiners look for. So telescopy test is very, very important, and Trendelenburg test is very, very important. These two has to be written in the exam. Then on the x-rays, you know it is because of the shallow acetabulum, proximal migration, break-in Shenton's arc, very, very easy. And if you can remember there are two angles, alpha and beta, right? And then this chart you have to put up x-ray. So this is the treatment, right? And now if you want to mention about the complications, so if you leave open your DDH like that, if it is neglected, it might result in severe osteoarthritis. And again, the treatment could be PHR or lumbar stenosis because of bilateral DDH. Could be few of the complications. And you can also write in case of bilateral DDH here, the patient will have the waddling gait, the duck-like gait in case of bilateral DD. Okay. So that is about the DDH. Fine, everyone? Any doubts? Samantha, Piyush, is that clear? Is DDH clear? Any doubts? Quick. Hip spica, you want me to repeat? Okay. What is hip spica? Sorry, I would have bought a picture, then you would have understood it better. Okay, no worries. So hip spica is, so usually these are two limbs, right? So here is the baby, right? And now what we do is you have reduced it. So the reduction is perfect, right? And now you have to maintain that reduction, right? Similarly, instead of using a splint, what we do is we apply the cast, POP. We apply the POP to the limb, the entire limb, and now this POP we even put to the abdomen like this. And sometimes we take the opposite limb also, half, only till the thigh. So this is called the hip spica. So the patient will have the plaster, the cast from here. So this is the cast. This is the hip spica. So now what we do is whenever we are putting this hip spica, again we put this in abduction position. The hip in abduction position, and we put a POP. That is plaster of Paris, with including the limb, the abdomen, and the opposite half of the limb, that is thigh. So this is called the hip spica. Clear? Spica is, you see, we have cast, we have slab, and then spica. Cast and slab is only for your limbs. Whenever you include the abdomen, then it becomes a spica. Right? Very good. Clear now? Okay. So DDH is clear. Any doubts you want to ask, or anything again you want me to repeat, or else we'll jump to the next question. Okay. So everybody are okay with the DDH? So now let's understand what is a Perthes disease. So once, next question, okay, Piyush is being bored about DDH now, so he has learned now. So next question is Perthes disease. So what is a Perthes disease? So before telling what is a Perthes disease, I want to introduce a term which is called as osteochondritis. Osteochondritis, again, when you dig deep into the definition of any word in orthopedics, especially, it is very, very easy. Now tell me, what is osteochondritis? So here the problem is there is inflammation of the bone. Osteochondrocartilage is inflammation. So there is some problem with the bone and cartilage, right? So whenever there is a problem, like especially in the epiphysis region, that is called as osteochondritis. And whenever there is an involvement of epiphysis of femoral head, is osteochondritis of epiphysis of the femoral head is called as Perthes. Very good. Osteochondritis of proximal femur. So to have to be very precise, it is the epiphysis, the femoral head, which is involved in the proximal femur. So this is the definition of Perthes disease, and what is the main cause of this? Okay. So there is some problem in the vascular abnormality, hence will result in the vascular necrosis. That is, so whenever there is absence of the blood supply, called as avascular, right? So ultimately, osteochondritis is nothing but it is leading to the avascular necrosis of the head. It is simply called as osteochondritis, and whenever this is involved in the femoral head, this is called as Perthes. Is that clear, guys? So this is the definition of Perthes, right? So once you have understood what is a Perthes disease, then you have to understand what are the risk factors for Perthes disease. So again, whenever there is a maternal smoking associated, it could be a risk factor for Perthes. So if the baby, if the mother has been, used to smoke during pregnancy, there is some amount of smoke exposure during pregnancy. So, Kalai, that is for SCIFI. Adolescent overweight hypothyroidism is SCIFI. That is clipped capital femoral epiphysis. This is Perthes disease. Perthes is some abnormality in the vascular, and the risk factors is usually the maternal smoking. So smoking is usually associated, and the deficiency of protein C and protein S and some thrombophilias in the mother can also result in this Perthes disease in the child, right? So these two are important, Yes, whenever is something related to vascularity, guys, medicine, remember this could be a thumb rule, something related to vascular, something related to vasculitis, or if the blood vessels are in, smoking will invariably be the reason. Okay, to cause avascular necrosis, there should be arterial only, no? So femoral, it is nothing but vascular anecrosis. The nutrition is not being given to the femoral head. So it is arterial, it is severe disease, right? And whenever something is related to vascularity, even if the burgess, some vessels are involved, usually the smoking has this tendency to deposit and create inflammation over the vessels. So especially the arterial vessels. Okay, so when this risk factor has been identified in Perthes disease as well, this maternal smoking, because vascular involved here. So you can think the smoking is somewhat related to it, right? Clear, everybody? So these are the two important risk factors. There are others also which you have to remember, but for me, what you have to remember is mainly this. So the maternal smoking, the thrombophilias, and sometimes the low birth weight also. Low birth weight babies are also at risk. Low birth weight babies. Okay. So these are at risk factors. So whenever you see a low birth weight baby, whenever you see some protein deficiency, protein is or some coagulation disorders and smoking disorders, also smoke. I think this you have to ask the OBG. Dr. Oshika will be the better person to answer this. Smoking is protective for preeclampsia. But for smoking is dangerous for us, especially in the Perthes disease. So it will cause some vascular abnormality, right? And usually, if you remember, this is seen in age group of 4 to 8 years. 4 to 8 years age group are more prone for Perthes disease because this is the age where there are certain changes in the blood supply of the femoral head. So if you go back to the blood supply of the femoral head, it is mainly by the epiphyseal blood supply, and then you have ligamentum teres, right? So because there are certain changes from the blood supply from one one certain arteries to other arteries, especially during this particular age group, that is 4 to 8 years. So this is being more seen. This is more, this birth is more frequently seen in this age, right? That is 4 to 8 years. So what happens in this Perthes disease? So first, what will be is there will be a stage of synovitis. So this Perthes disease is a self-resolving disease. What you have to remember is this is a self-resolving disease. So it goes through certain stages. So first is stage of synovitis. Then it is stage of fragmentation, right? Then it is stage of recalcification. Then it is a stage of healing, right? Guys, are you following? So this is a stage, the Perthes disease, no, it is a stage, is a self-resolving disease. That is, there will be some abnormality or some disturbance in the vascular supply, and now again the head will go into avascular necrosis, as I've told you. That is, there will be deformation of the head, and again this head forms to heal by its own. So this is a self-resolving disease, and what we have to do as a treatment is, just what you have to do is, you have to do containment procedures. Containment procedures means you have to see that during this problem of Perthes disease, this period of where there is some abnormal vascularity which is happening, you have to see that the head is sitting into the acetabulum. That's it. If the head is sitting into the acetabulum, it will heal by itself. But if you don't see, or if you don't make sure that head is sitting, and if the head is not into the acetabulum, it will go into coxa plana or coxa magna. So the head might become flat or head will become big. Again, it will not sit into the acetabulum. So what is your role here? To see that head is sitting in the acetabulum. That is what you have to do. Understood? Guys, are you there? Piyush, Kalai, Samantha? So what is the first stage? Stage of synovitis. That means there is some problem in the first stage where there will be flexion. So just the cartilage is affected here. The synovitis is nothing but the synovial fluid is increased. So this will go into flexion, right? Okay, you want me to repeat the stages? So these are the 4 stages, right? So what you have to remember is, so for Perthes disease, just remember it is some vascular abnormality, right? And this will usually seen in 4 to 8 years of group. And in this, it is a self-resolving disease. So the first one is stage of synovitis. So only the hip is inflamed. That means there is some irritation to the synovium, and now there is an increase in the synovial fluid, which will result in synovitis. So inflammation of the synovial or synovial fluid increase, right? And then there will be stage of fragmentation. Stage of fragmentation is then where you will see that the femoral head is deformed. You cannot see the shape of the femoral head. You can see some fragments of the femoral head. So this is the stage of fragmentation. And then you see again it will reossify. So again it will form its own, right? So you can see some amount of depositions, that is stage of recalcification, and finally it will heal. So this is stage of healing or stage of remodeling. Understood? So this is stage of healing or stage of remodeling. So these are the 4 stages which the Perthes head or the femoral head goes through. And what is your role in it? Whenever you see such Perthes case, what you have to do? You have to make sure that head is sitting in acetabulum, right? So you have to make sure that you're putting the head back into the acetabulum, and that is called the containment procedures. That means you're containing the head into the acetabulum. If you don't do this, then it will go into coxa plana. That means the head will become a flat surface, or it will become a huge coxa magna, deformed head, huge head, where it will again not sit into the acetabulum. So that is the thing with the Perthes disease. So these are the stages of Perthes disease. And now how the patient comes to you. The patient will come with pain in the hip. Pain in the hip, then there will be no trauma associated, and you will see that there is a limitation of movements. So what are the movements which are limited here? So the movements which are limited here is the patient will not be able to abduct, then internal rotation. So these two are important things which are painful for the patients. Abduction in internal rotation. And then, so how the patient tells you that? So the patient will tell you there is difficulty in in- so this is how the clinical signs and symptoms the patient will tell you. So then what you see, sometimes there is a pain radiating to knee also. Right? Sometimes the pain is radiating. Understood? So because the head is deformed, what is the signs which you see? The patient present with painless limp, and there will be increase in external rotation called as obligate external rotation. Okay. Neha, yeah, yes, we have batches for second years also. Yes, you can go to the app. I mean, you can go to the app and purchase that, where there are regular live classes for the second year students. Download the app and you can purchase through it. Okay, Piyush, Kalai, and Samantha, is that clear? The Perthes stages, and then we are done with the clinical signs and symptoms. So first one, what you have to remember is there would be a limited pain only for limited period. Then the patient will go to painless limp. Okay, and then there will be limitations of the movement. So what are the important movements which are limited? One is the abduction. If you remember the abduction, what we have done with the DDH, and then the internal rotation. Internal rotation is towards inner side, towards the medial side. The femur is rotated. I mean, the entire leg is rotated towards the medial side. So that is the internal rotation. These two will be limited, right? But what will be increased? The external rotation will be increased. The external. And what the patient usually complain? Limited pain matlab, so they will not, when they come to, they don't come with the pain, they come with painless limp. But initially when the stage has started, when the has started, the pain will be there. There we have small slight pain in the hip during the stage of synovitis. During the stage of synovitis, whenever there is inflammation, they will have pain. So during that, pain will be reduced over a period of time, and then they will neglect that. But when they come to OPD, usually they will have painless limp. So whenever you see a painless limp, one of the most important differential diagnosis for painless limp is your Perthes disease. Understood? And then you will have this, sometimes they have this pain which is radiating to the knee. Very patients will present with this, and then there will be obligate external rotation. That means whenever you try to flex the knee, whenever the patient is sitting on the couch and now you're trying to flex the knee, it goes into external rotation, right? So that is called as obligate external rotation. Okay, so these are the signs and symptoms. And going back to your radiology, already you have seen that the head is deformed, and there are certain things which you can identify which are called as the risk points. So based upon this marks, or based upon this, so whenever first the patient has, so you can just think this way. So because it is going through the stages, it is a self-resolving, as we have told you. Initially, when it starts, it is accommodating. So it will present with the pain. So synovitis is the inflammation. Once the inflammation is decreased, when it goes into stage of fragmentation, when it goes into stage of recalcification, it is somewhat gets adapted to it. So then you will not have any pain. So whenever there is synovitis, that time you will have pain, and then over a period of time the pain will get subsided, right? And now what happens is the pain gets subsided, and now there will be limitation of the movements, like the patient will now have difficulty in squatting or sitting on the floor. So as you take the history, she will tell over maybe some 3 or 4 months back I had small pain, slight pain, but it got reduced. So they will think this is that was because of some extra work they have done or something extra they have done at home and all. But usually this is because that stage was stage of synovitis, and when they come to you during the third or fourth stage, there will be no pain, right? And now they present to you as painless limp. So there will be limp which is painless, and then you have your limitations of movement. So these two are very, very important. So first there will be limp, and then there will be limitation of abduction and internal rotation, right? This is how you diagnose, and when you take the x-ray, you will see this type of picture. So you see this type of picture. So there is some problem with the head of the femoral epiphysis. So whenever you identify this, and especially if the patient is age group of 6 years or 5 years, then your first diagnosis would be Perthes disease. First diagnosis, Perthes, right? And now sometimes what happens is, if the patient present to you early, what you can see is with lateral subluxation of epiphysis, or lateral calcification, or a metaphyseal cyst, or you can see a gaze sign. Gaze sign is something in V shape in metaphysis and epiphysis of lateral head. So these are called the at-risk signs. Means these are the signs where you can tell the patient may land up in Perthes disease, right? So this is the lateral subluxation. That means what you see is head is slightly towards on the lateral side, and sometimes you can see lateral side some calcifications can be noted. And metaphyseal cysts, cysts are something which are fluid filled things which are seen on the metaphyseal region, or a V-shaped defect. This is a gaze sign or V-shaped defect which is seen on the lateral aspect again. So whenever these things are present on the lateral aspect of the epiphysis, you think that at risk of Perthes, at risk of Perthes disease, is at risk of Perthes disease, right? And one more thing is horizontal physis. Horizontal physis. So these are all at risk for the head to get into Perthes disease, right? Clear, guys? And now, as I told you, so this is nothing but this might lead to avascular necrosis finally. And whenever you deal with avascular necrosis, and the investigation of the choice would be MRI. These are all on the x-rays. So on the x-rays, whenever you take the x-rays and you see certain things like this, so you can you can tell the patient that this head is at risk of entering to AVN. And investigation of choice for avascular necrosis is your MRI. So once you take the MRI and you see that the patient has avascular. And now what is the treatment for it? The treatment, as I've already mentioned, that this is the containment procedure. So how do you contain it? How do you contain it? Okay, what is gaze sign you want to know? So gaze sign is nothing but it is like this. So on the lateral femoral epiphysis, on the lateral side, if you see this is the lateral side, so this is a defect which you can see. So it will be in a V shape like this. It could be on the epiphysis or the metaphysis. So whenever you see a V-shaped defect like that, then it is your risk of the head. So these are all nothing but to understand which heads are at risk of developing AVN, right? So this is one such sign is your gaze or V sign. The second one is lateral subluxation. Similar. What is subluxation? Subluxation is nothing but movement, right? So this epiphysis is seen outside. This is the lateral subluxation. So this, whenever there is a defect like this on the lateral aspect, so that is the V-shaped defect. That is called the gaze sign, right? And if you see metaphyseal cyst, so some cyst if you see on the lateral aspect of the metaphysis, then again you can tell the patient that you are at a risk of developing Perthes disease. So these are all not, these are all just a signs of how to identify a head at risk signs, right? And containment procedure, as I've mentioned, then you always put again this limb into abduction. So this is done by Petrie's cast, right? It is done by the Petrie's cast. And again, what you have to remember is we do with the osteotomy. So here we do a varus osteotomy for the femur, right? If the patient is of more than 8 years, then you can go for a right? So 4 to 8 years of age, you can go for a femur varus osteotomy. Again, what is a varus osteotomy? You cut the femur at the level and then you put the head into varus position like this, right? So this is valgus position and this is varus position, right? So this you cut the head and put it into varus so that it will sit in the acetabulum. So that is your varus osteotomy of the femur. So one is abduction position for the Petrie's cast. I have discussed again. So Petrie's cast, or again you can put a splint into abduction. And then after 4 to 8 years, if the patient is less than 4 years, you go for Petrie's cast. If it is more than 4 years, you usually go for osteo. And if it is more than 8 years, you go for acetabulum. So that is about the Perthes disease, right? So this is a very, very important question again. Is that clear, guys? So now there have been a question which was asked, can you differentiate between DDH and Perthes? So Perthes is also called as coxa plana, as we have discussed. Plana is again the head becoming so very plain, or it is becoming flat. Surface has been become flat. Can we do a skin traction? No, skin traction here it doesn't help. Skin traction doesn't help. So depending upon the position of the head, you can go for a varus osteotomy, right? So here, if you see, most important things is, we'll just go quickly, briefly, so that it will be a revision also. So definition, we know it is an abnormal development where this subluxation or the femoral head and acetabulum are not aligned to each other, and this is because of temporary disruption of the blood supply. As we have told, this is a self-resolving, as I've told you. So this is a temporary disruption. So since this is a temporary condition, in this condition, what you do is you try to put the head into the acetabulum, right? Again, you usually see this in the newborns, right? Newborns or infants, but this usually seen 4 to 8 years, right? And here it is usually the males. Here it is, because progesterone is high in the females, because of that laxity could be high in females. So that is why somehow it is related. DDH is related to female. So we have learned the hormonal influences, that is progesterone, breech position learned, and this is due to some blood supply ischemic. So usually the perthes is said to be idiopathic, which is linked to some blood flow disruption in the head, right? And this is necrosis of the femoral head. Here the femoral head will come outside the acetabulum, and this is a condition of instability. So here the pathology is mainly the instability. Here the pathology is mainly regeneration, that is necrosis of the femoral head followed by regeneration. But if you don't put the head back into the acetabulum, there will be deformation. Deformation is coxa plana or coxa magna. This we have learned, that asymmetric folds, Galeazzi sign is seen. Here you see pain sometimes, which is radiating to knee, but it is painless limb usually, and abduction and internal rotation is restricted. X-ray is shallow acetabulum, break in sentence, this all we have seen. And X-ray you can see there is a sclerosis, that is increase in the density, fragmentation, and sometimes you can see there is a collapse of the femoral head, that means coxa plana. And investigation of choice to identify it is, right? And then treatment, you see this is 6 months Pavlik harness. First try closed reduction, then go for open reduction, and older children it is osteotomy. Here usually we go for physiotherapy initially, non-surgical if you want to go, but anyways once we see the perthes we go for containment procedures, that is varus osteotomy of the femur. Remember, varus osteotomy of the femur. Prognosis, early prognosis, if the treatment is really good, if you identify by newborns, so screening is very, very important for DDH, the outcomes are really good. And it depends upon the age, and sometimes if you get delayed, it may land up in avian or complete deformation of, right? So this is the main difference between your DDH and the Perthes disease. Is that clear? Both of them very, very important questions. Clear, everyone? Clear, guys? Yes, I need a quick review from you. Is that clear? Anything is disturbing your mind, or you want to listen it again? All good? Want me to repeat the differences again? Difference is the same, no? What we have dealt is only difference. Okay. Samantha, I'm repeating it again. So differences is, first DDH, the definition, what you have to remember is the femoral head and the acetabulum are misaligned, right? So this is all because of the pathology point. Okay, pathology point is, so whenever the femoral head is not aligned, this will lead to shallow acetabulum. We have discussed, right? See, always in the human body, whatever is formed is because of the process it has been undergoing, right? If the femur is in its shape like this, that is because the stress which has been applied on it, right? So similarly, the acetabulum and head, if they want to form really good, good bonding has to happen, they both has to be together, right? So we are making them together. So whenever the femoral head is not in the acetabulum, what will happen is, now the acetabulum will think that nobody is there for me to go deep, so the shallow is enough. So this much of shallowness is enough. So that will lead into what is called as shallow acetabulum, right? And whenever the acetabulum is shallow, if the femoral head again wants to come inside, there is no cup for it, right? There is no cup for it. So this will lead to instability, right? It will lead to instability. So the femoral head is continuously outside the acetabulum. That is in D. Whereas in Perthes, what happens is, Perthes, there is everything related to blood supply. So because the blood supply is disrupted, there will be necrosis. What is the end thing of any ruptured blood supply? It is necrosis, right? So this necrosis of the femoral head, again, because this is only temporary disruption of the blood flow, temporary disruption. So again, there will be regeneration. And once if this regeneration, during the process of regeneration, the head should sit in acetabulum. The head is not sitting into the acetabulum. It can possibly deform. So this deformation is, it could be a coxa plana, which is nothing but the head becoming completely flat, or coxa magna, or head becoming very big, so that it will again not go into the acetabulum. Both of this will lead to pain. Even if it is plana or magna, that means again the hip is completely deformed, right? So we have to treat it with THR again. That is the pathology point. And rest all is same. What we have dealt into, I have put it in a table. That's it. Clear? Okay. If you're clear with DDH and Perthes, we are going to another interesting topic, that is your congenital talipes equinovarus. Very, very important, and it is a very long question. It is important for your prof, important for your Viva, important for your NEET-PG, important for your any exam you're going to attend. And if they want to ask a question for pediatric ortho, it could either be a DDH or C. These two are very, very important topics. And then comes your Perthes and finally your skiff. Okay, where has Kalai gone? Okay, Kalai, are you back? Done. Okay, now let us deal with a very, very interesting, very, very important topic of pediatric ortho, that is your congenital talipes equinovarus. As again, I'm telling you, everything will be the heading itself. So we have dealt that the Perthes disease, nothing is there in the head because it was discovered by leg, calf, Perthes. This is the name of this is this because it was discovered by leg, calf, and Perthes. Leg is two. So these are the three important persons who have discovered the osteochondritis of femoral head. Hence, it is named as leg, calf, Perthes, right? And now this is congenital talipes equinovarus. So what do you mean by congenital? Congenital meaning is it is from the birth, right? Congenital is during birth. And tally and pes. What is tally? What is pes? Tally is nothing but ankle. Pes is nothing but foot. So this is a birth condition in which ankle and foot is affected. How it is affected? The foot is going into equino, that is plantar flexion, and is going into varus. So this is the definition, is deformity of ankle and foot during birth with plantar flexion, varus, adduction. Okay. Right? So these are the deformities. You can complete it as deformities of ankle and foot formed during birth. That is nothing but your CT, right? So this is a little, I bought this one because to understand what is equinus. Equinus is plantar flexion, means walking on the your toes, like the horses. So horse is equina. So equinus is walking like, right? Varus is mainly in the hind foot. So this is the varus, right? And this is cavus. Cavus is nothing but your arches are elevated. So this is planus. So arches are flat. So the flat foot, and cavus is cave-like foot, right? And then your splay. This is called the splay, which is we usually don't see in CTP. So what are we more concerned is about the deformities which are occurring in the ankle, which are formed during birth. So what are those deformities? One is plantar flexion, right? One is plantar flexion, then you have varus, when you have adductors, then you have cavus. So these are the deformities. How do you remember it? Just remember the mnemonic C, A, E, and E, right? C for cavus, A for adductors, V for varus, for E. So this is how you have to remember. These are the deformities. Yes, very good, Piyush. That is cave. So this is the deformities which you have to remember whenever you're writing CTEV. By that, we finish the definition. Now, what is the pathology? Why it is actually happening? It is happening because of crowded uterus. Okay, crowded uterus. What happens is, in this, what happens is usually the talus present is going downwards medially. So the talus, yes, is because of that it is underdeveloped, that is hypoplastic. It rotates downwards and medially. Because of this talus is rotating like that, what happens is the surrounding bones, the friends of talus, that is calcaneum, void, navicular, also rotate. Now they make the foot words. So because of that, what happens is the ligaments, tendons, posterior, effect contracted. So this is the mainly the soft tissues. Finally, the joints subluxated. So what is the main joint? Talonavicular. Okay, they all get right. So that is the pathology which is happening. Very, very important. So everything starts with the definition. So what is the definition? There are certain deformities which is happening. So these deformities can be remembered. It cave, that is cavus, adductus, varus, and equinus, right? And then the pathology start with the crowded uterus, so that there is no space for this, the foot to be straight like this, so it gets inverted. So during this, the first main culprit who is under this is the talus. The talus is the main personality. Oh, main personality. So talus is the main personality where the talus goes into, yeah, inversion only. No, everything we're talking about, it goes into inversion. Like the inversion and eversion which occurs at the subtalar joint. So everything is inverted only. No, that is there'll be inversion. So what happens is, now the talus, whatever the talus is there, now it goes downwards like that and it turns medially. Because of that, the surrounding structures, the calcaneum, the cuboid, the navicular are also deformed. And now the foot will go into inversion and the hind foot. So what you have to remember is, here there are foot. So this is your hind foot, where only two structures, the calcaneum and above it is the talus, right? And your tarsal bones here. So this is your midfoot, and all this is your forefoot, right? So this you have to remember. So which one is what? So this hind foot will go into varus, and this midfoot will go into cavus. This forefoot will go into adduct. And equinus, you all know? That is your ankle. Right? Is that clear? So this is about the pathology. What you have to remember is only this much. So first the problem starts with the talus going like that, taking all these things, and then the ligaments and the tendons which are present around it, especially the posterior medial tendons and ligaments, they get contracted and shortened, and then the joints all will get deformed. What are the three important joints? The talonavicular, the talocalcaneum, and the calcaneocuboid. So these are the joints which are mainly involved. So here the problem starts with this contracted soft tissue, right? And when do you identify this? So when do you identify this? You identify it at birth only, no? So you see that there is clinical diagnosis. So clinical signs and symptoms, it is clinical diagnosis, you see. And what is that one screening test you do? What is the screening test? Yeah, equinus is due to tibialis posterior. Yeah, that is ankle. Ankle, in ankle, you see that shortening of the tibialis posterior. No, it is because of both. The tendoachilles is on the posterior aspect, the tibialis posterior is on the medial side, right? Because of the shortening of that, because of the ankle deformity. So here the screening test, again, that is what I'm telling you. The screening test, you cannot do the dorsiflexion. Not touching the shin. Yeah, normally what happens is whenever you dorsiflex, normally it touches the shin of the tibia. But in case of your this CTEV, it will not touch the shin. So this is because of the tendoachilles contracture. Usually it goes into equinus, and varus is because of the tibialis posterior. Yeah, you can, if you want to choose the best out of it, it is tendoachilles. Equinus is of tendoachilles. That's why for the correction of the equinus also, you give a nick in the tendoachilles, right? So that is why it comes into dorsiflexion, right? Yeah, you can take that answer as tendoachilles period. So this is the clinical diagnosis. Clinical diagnosis is mainly, it is clinically you can see and tell that is CTV. So you can tell whether it is unilateral or a bilateral CTV. And again, associated conditions, if you remember, associated with the, it is again DDH, metatarsus, right? And again, incidence talk, it is 1 in 1,000 live births. Right? Okay. So that is about the CTV, pathology and incidence, associated conditions. And what you have to, and one more is torticollis. Torticollis. These three are usually vectorial anomalies. Yes, sometimes it can be associated, but I'm not very sure about the vectorial anomalies with the CTEV, but these three are associated conditions. So one is DDH, one is metatarsus adductus, and the third one is your torticollis. So whenever you see these conditions, you have to screen for. And what you have to remember is there are certain terminologies for CTEV. So this is primary. Usually it is idiopathic, and secondary, it could be associated with orthogyropsis multiplex congenita. This is a group of anomalies, right? Group of anomalies. So how is the CT scoring? So once you see the baby of the CT, you do Irani scoring. So you will tell whether this is a supple CTV or a rigid CTV, right? If it is supple, you can manage it. If it is a rigid, then again it is an aggressive management, right? Okay. So Pirani scoring you do if it is supple. That means if it is really malleable, then you can go with a general treatment, or it is very rigid, then you have to give an aggressive treatment. So how do you treat it? So very, very important. Then everything is your treatment of. So once you have diagnosed, so treatment you will see for other anomalies also, and you decide whether this is simple or a rigid CTP. So any CTP, you always start with the serial casting and manipulation. So serial, what do you mean by serial casting and manipulation? We'll do the POP. Plaster of Paris above knee, right? And every week change the plaster. What is the maneuver which we do? We follow the Ponseti's technique. So this is universally followed Ponseti technique, who has done a very extensive research on how to treat this. So he will follow again cave. So this is of order of the correction. Order of correction. Yes, this is just on the day of birth also you have to do. The patient is all fine and good. Yeah, ASAP, as early as possible, even on the day one, right? You can start on the day one also. What you have to do is you have to motivate the patients, you have to motivate the mother that this serial manipulation will help the baby to attain the normal feed, right? So first we'll always start with the cavus correction, then you correct the adductors, then you correct the varus, finally you correct the, this is the last. And what was the history of this? So it was history, the kites method, which is obsolete now. And if this is not followed, you might result in a complication, that is rocker bottom foot. So how do you do this again? Yeah, this is improper correction. Yeah, whenever you don't follow, or when you not do improper sequential correction not followed, then you result in rocker bottom foot, right? You result in rocker bottom. Understood? And now and now what you do is, this is up to correction of the, so usually it will take about some 5 weeks, 5 weeks to 6 weeks. Then final step is correcting the equinus, right? So this equinus is corrected by tenotomy. So tenotomy is nothing but you give a incision of the endoachely. That is tenotomy. Casting after 6 months? Not for 6 months, just weeks. Every week you keep correcting, right? So usually by 5 to 6 weeks or 8 weeks, it gets corrected. And last step of correction is your last step. This is the last step. Then this last step is correcting your equinus. So how do you do it? That is by tenotomy, right? Yeah, I will tell posterior. So this tenotomy, you give a slight incision over the tendoachilles. Just you put the needle like this, and then you do a transverse incision. That, and now you can dorsiflex the foot. You dorsiflex, and again you will put the POP. So now it is done. So once the patient has been corrected, then how do you maintain it? So you maintain by your Dennis Brown's. Very, very important. So you maintain it by your Dennis Brown splint. So here what you do again, abduction, external rotation of feet, and first 3 months it is for 23 hours the patient has to wear. Yes, abduction foot orthosis. Very good. It is also called as abduction foot orthosis. So after 3 months, you go for 12 hours sprint flexion exercise, right? And when the patient starts walking, go for, right? I think you are very well versed about what are CT. So this is your Dennis Brown splint and this is your CT. So after correction of foot and ankle deformity completely, then maintenance by these two, this and this. So CTV, you know, just again 3 important things. The first one, what you have to remember is the straight inner border. The inner border has to be straight, the foot end has to be raised, and there is no heel if you see. So if it is a heel again, it will go like this, right? In plantar flexion. So the foot should be straight. So there is no heel. And again, instead of going inward, you will raise the outer. So there is no problem of going inward. So instead you put it like this, abduction. And there is a straight border. So these three have to remember for CT use. This is for a walking child. Walking child. And this is for 3 months after correction. Right, that is your Dennis Brown splint. So there's a bar in between, and again this is put in abduction and external rotation. Right, so this is about the maintenance of the foot. Now comes to, okay, now we will see if the patient has come, if it is a rigid CT or a neglected CT, right? Even if it is a rigid CTV or a neglected CTV, always try casting, right? Always try casting, always casting. If fails, the first thing is soft tissue procedure. So what is the soft tissue procedure? Yes, that is your posterior medial soft tissue release. What do you mean by posterior medial soft tissue release? In the pathology, we have already learned that the posterior medial structures, that is tendoitis, your tibialis posterior, and all those structures on the posterior side, on the medial side, they get contracted and they get shortened. So what is the main theory of CTV? You have to make the foot has become like this. You have to make the foot straight, right? So this side, all the medial side has been contracted. It is into cavus like this. Now what you're doing, it's into cavus. Now what you do it straight and you make it flat like this. Do it straight and make it flat. So for that, what you have to do, posterior and the medial structure, you will release. So this is called PMSR, posterior medial soft. So this you can try for up to like 3 years. So like 3 years you can read, right? And again, if at all this is not doing anything, then you can go for bony procedure. So certain bony procedures you have to remember. So in that, again, once you correct the cavus, then is varus, right? So varus rotation osteotomy, right? After varus, what do you correct? Then you can go wedge tarsectomy. Finally, triple arthrodesis. What do you mean by arthrodesis? It is fusion of the joints. So now I will explain you. So this is a soft tissue procedure, that is PMSTR. Now I'll explain you the bony procedure. So help of this diagram. So if you see, this is an open wedge. So here we are correcting the varus. So where is actually varus? Varus, it is usually in the hind foot, as we have discussed earlier. So the calcaneum will go into varus or valgus, right? So this varus is corrected by, again, osteotomy. If you remember, wedge shaped osteotomy. Similarly, we have done for acetabulum in DDH. Here again we are correcting. So now the bone is something like this. It has been into varus like this. So what we are doing, we are taking out a structure on the medial aspect. So one wedge shaped structure, you have to measure the angles and you will measure the wedge and remove a wedge on the medial side, so that you are making the lateral side straight like this, right? So you do lengthening on the medial side. You are lengthening on the medial side and shortening on the lateral side. Always remember this. You have to lengthen the medial side because the medial side has gone into contracting and shortened. So medial side is always lengthening. Medial side lengthening procedures. So again, how you do medial side lengthening procedures? So again, you do wedge tarsectomy. See this wedge tarsectomy also. This is your medial side and this is your lateral side. So again, you're taking a wedge shaped tarsals here. Some of the bones you're taking, so that again you're correcting the bone. You're correcting the foot. So this foot again, once you remove this wedge shaped structure like this, then you can turn it this way. So again, it becomes straight. So medial side you are lengthening and lateral side you are shortening, right? And finally, if you can't do anything, you have done all the bony procedures, soft tissue procedures, what you do is these three important joints, the talonavicular, the calcaneocuboid. So this is the talocalcaneum, talonavicular, calcaneocuboid. So these three important joints you fuse, and this is called as your triple arthrodesis. Triple means three. Arthrodesis. What do you mean by arthrodesis? It is a surgical fusion. So arthrodesis is nothing but your surgical fusion of the joints. Arthrosis. Okay, arthrosis is fusion, pathological fusion. This is a surgical fusion. Arthrodesis, right? So in this you take three joints. What are the three joints we have already dealt? So one is talocalcaneum, talonavicular. So on the medial side you have navicle, lateral side you have cuboid. So this talus and this is calcaneum, right? This is navi. So all these joints you fuse so that the foot again becomes straight and stable, right? And now recent advancement is you can do a just fixation. That is an external fixation of a just fixation. You can do and slowly correct it, right? Just remember this one. It is again an extra edge for you, more marks, right? So this is the just fixation which you can do. So that is the treatment. So you have to remember, first you start always with the serial casting and manipulation, and then you followed by this serial casting and manipulation is by your Ponseti's technique. Very, very famous, very well researched, and the correction is almost 100%. So it is 80 to 100%, right? And then there is an order, that is cavus. So you have to remember the cavus is in the midfoot. So first you're correcting the cavus, then the adductors, that is in the forefoot, whereas in the hindfoot is in your ankle. Understood? And after correction, how do you maintain it? You maintain it by two things. One is your Dennis Brown splint, and second one walking is your CTE. And now if the correction is not proper, or if there is a rigid CTV, what you do is two things. One is soft tissue procedure, which is posterior medial soft tissue release, because we already know that the posterior and medial structures are shortened here. So we have to increase their length, right? And then after 3 years, the 3 years you go for what is called as bony procedures. There are again various procedures, varus osteotomy mainly for calcaneum, wedge osteotomy for tarsals, and for joints you fuse that triple arthrodesis and recent advancement, yes, fixation, right? Clear everybody? That is your CTEV. Any doubts? So once we are done with CTV, we can go for the joint disorders. Ah, yeah, I forgot the kites angle. I'm sorry, Kalai. So kites angle. This is one thing which you can observe on the X-ray. So kites angle is nothing but the angle made between talus and calcaneum. So whenever you take an angle of talus and calcaneum, it is usually more than 35 degrees. But in case of CTEV, what happens is this becomes 0 degrees. So the talus and the calcaneum are like this. So you draw a longitudinal line on the talus and the calcaneum, it has become like this. But normally the talus is like this and calcaneum is like this. So this angle is somewhat 35 degrees. So this is called as parallelism. This is called as parallelism in CT. It is nothing but kites angle. Talo calcaneal. Yes. Can you give one tip for scoring good in ortho? Do all the previous questions, right? So you can read all the previous year's questions for good in ortho. Ortho is actually a little easy because it is more of logics and it is more of concept. So if you understand little concept, no, you can answer them. Like mugging up and then you forget, not like your Dharma and Psych where a lot of revisions. Once you understand the concept, it becomes easy. So kites angle is done. Anything I have left, Kalai? Okay, Samantha wants me that bony procedures to be repeated. Okay, for Samantha, we are repeating the bony procedures. So Samantha, whenever you're attempting the KCT, you have to remember that first always casting. Then after casting, there is maintenance. After maintenance, if it is not corrected or if there's difference or if problem, go for a soft tissue. If the soft tissue is also not able to address your problem, then we have certain bony procedures done after 3 years of age. So that first one in the varus. So as you all know, the varus is usually seen in hind foot, right? So here what we do is in hind foot is calcaneum. So calcaneum, we are doing a varus osteotomy, right? Varus is on the medial side, we are taking a wedge of the bone you are cutting. So you imagine there is a block and in that you take a piece of wedge. Now this becomes free, right? So whenever this becomes free, we are rotating it. So here what we are doing, we are lengthening the medial aspect, right? So whenever we lengthen the medial aspect, this becomes straight. Now it was like this. So this was shortened, this was lengthened like this. Now what we have done, we have make it flat like that is first one, varus osteotomy. The name given it is Weyer's osteotomy, right? Second one is wedge tarsectomy. Wedge tarsectomy. So a wedge shaped tarsal bones. So these are the tarsal bones. Again, you always target the navicular, the cuboid, right? So this navicular cuboid involved, you are removing a part of the wedge shape again to make the foot straight. That is called as wedge tarsectomy, right? And finally, if nothing is working out, or these wedges are not helping you, you fuse all the three important joints. So what are those three important joints? The first one is subtalar or the talocalcaneum. This is the talocalcaneum. The second one, what you fuse is a talonavicular, and the third one, what you fuse is the calcaneocube. So when you fuse all these three, this is called as arthrodesis. So whenever you use the term arthrodesis, that is nothing but the surgical fusion. Okay, then what is the opposite of this? Opposite of this is ankylosis. Ankylosis is pathological fusion. That means some problem has been occurred such as infection or inflammation and the joint has is ankylosis. But this is arthrodesis. Arthrodesis is surgical fusion. So you are fusing the joint becomes flat. The patient will able to walk. So these are the three important procedures you have to remember. And finally, recent advancement is a JES. JES is nothing but Joshi's external stabilization, that is X fix. So what they do is, with for this foot again they put rods and pins, and now they try to correct it, right? So that is again a aggressive uh, form of treatment which is being used, so that you fix all this with X fix, and daily you uh, correct the angulation of the foot. So that is the recent advancement. What you have to remember, that yes, fine. Samantha, is that fine? Okay, just okay, or else you understood. Was I fast in repeating also? Got it. Okay, good. Okay, now as we have done with the pediatric ortho, so there is a high yield for you. So we have done osteogenesis imperfecta, achondroplasia, DDH, births, TV, very, very important questions, right? So I expect at least one out of them, and you're going to write it very, very neatly and clearly with relevant diagrams. That is very, very important. And what is important is highlight the point. So if you're writing something like, see, in CTV you're writing kites angle, or you want to highlight parallelism, you have to underline it. So take another color of pen and just try to underline it, so that the person who is correcting will subconsciously will look at that highlighted point. So whenever he sees such words, no, he will be very happy. Fine. And this also, whenever you're writing about the CTV, you have to mention that underline walking child and put CTV. And nothing to write more about CTV. 1, 2, 3. First, straight inner border, outer rise, no heel. That's it. Your marks are done. Okay. That is how you have to present. It should be in a presentable format. Okay. That is important. And now finally, we are done with the pediatrics, and now let us see two important joint disorders. Okay, so first one is rheumatoid arthritis. I'm going to teach you. The second one is osteoarthritis. So 8:40, 10 minutes we'll do rheumatoid, and the other 7 or 8 minutes which is left out, we'll do osteoarthritis. Probably by 9 or 9:10 we'll close the class. Okay. Okay, so first, what is rheumatoid arthritis? Again, a very, very important question which comes to your ortho paper. So whenever we say rheumatoid arthritis, again going back to our basics. So what is arthritis? Because arthritis is, arthrus is nothing but joint. What is a joint? So what is a joint? Joint is nothing but a part where it has articulating surfaces and there are types which is covered by synovium, so filled with synovial fluid, right? So there are articulating surfaces, there is cartilage which is present called articulating cartilage, then there is synovium, synovial fluid, right? And whenever this is inflamed, inflammation of this articulating surfaces is called as arthritis. So this arthritis, we have two important arthritis. One is inflammatory arthritis, another one is degenerative arthritis. So what is inflammatory arthritis? Is your rheumatoid arthritis. Understood? So the definition is, this is an inflammatory arthritis and characterized by polyarthritis. So always to diagnose it as rheumatoid or inflammatory, it is polyarthritis, autoimmune nature, right? So these are the two important points, which is the characteristics of rheumatoid arthritis. So one thing, whenever you say somebody is suffering from rheumatoid arthritis, the first one what you have to think is it is an inflammatory condition, right? And it is characterized by polyarthritis. So multiple joints are involved. And why multiple joints are involved? Because it is an autoimmune condition. So what is the pathology? So pathology is mainly genetics. Pathology is mainly genetics, where there is a release of inflammatory mediators. This could be because of HLA-DR4 involvement, that is genetic. Then it could be mutations, infections, where antibodies destroy. Yeah. And what do you mean by autoimmune? Autoimmune, self antigen presenting cells. So for this, bodies are produced. Okay. Okay, so this is the pathology. So what is the main pathology is, so you have to remember that this is an autoimmune disease. So autoimmune is the meaning of autoimmune. The body itself is producing the antigens, right? For that antigens, antibodies also are produced, self antibodies, which will result in destruction, will result in the destruction, right? So these antigens can be their own antigen presenting cells, or they could be, these antibodies can be produced by past infection, right? And now what these antibodies do, these antibodies will destroy your own. So this cartilage, so usually involves the articulating cartilage, right? So these joints are involved, hence will result in or polyarthritis. As I said, it is autoimmune, so mostly seen in young female. And for this, for diagnosing, what is the main important criteria? It is according to 1987 criteria. The first one is morning stiff. So at least 1 hour of morning stiffness, 1 hour of morning stiffness is involved, and polyarthralgia or polyarthritis is very, very important. Yeah, this is also early morning stiffness. Very good for correcting me. So very important. It is an early morning stiffness. So what is an early morning stiffness? That means the inflammatory products, oh, the whole night the patient will take rest of the joints, and as he get up early in the morning, all these inflammatory products get accumulated in the joint, and now they will cause joint pain. So that is why the patient will have, that is why the patient will have early morning stiffness. So this will be at least 1 hour of early morning stiffness and involvement of 3 or more joints. So that is why it is called as polyarthritis. And these 3 or more joints, mainly this should be in the hand joint. So these hand joints. So usually the MCP and the PIP is involved. The MCP and PIP is involved most commonly, hand joints, MCP and PRP. Yeah, DIP are usually preserved. And it is usually a symmetric arthritis. It is a symmetric arthritis. And now, after these four conditions, what you see is, you see the rheumatoid nodules. These are the nodules which are formed because of the deposition of the antibodies. So there are the rheumatoid nodules, and there is a rheumatoid factor, RF factor, which is called, and this is again an antibody which is produced, and then you see certain radiographic changes. So these are all first four are very important, and next these three are supportive. Next these three are supportive diagnosis. So 4 out of 7 has to be present. And in that, the first 4 should be of 6 duration. Yeah. And one more thing, yes, once you start using the joints like this, once you start using, the inflammation, the swelling will come down and the patient will become free over a period of time. That is one of the most important symptom or the sign which the patient tells us in the OPD. They come with the early morning stiffness and they have presence with the multiple joints, that is 3 or more joints, and especially the MC, the PI word, and usually they are seen the hands or both the legs and both shoulders, the bilateral, right? And then sometimes you can even feel for rheumatic nodules and test for this. There are certain changes which you can see the X-ray, the radiographic change. Akash Patel, ma'am, can an average student survive in MBBS? Absolutely. I was an average student surviving, right? So you can also do. So this is the diagnostic feature. So this is very, very important. So once you are done with the definition and once you're done with pathology, the next thing what the examiner looks for is the diagnostic criteria. You're going to write all the 7 points without forgetting, and you have to write 4 out of 7 has to be present, and the first 4 things when they're present, they are present for more than 6 weeks of duration. So that is the diagnostic criteria. And then comes the deformity. So very important rheumatoid is the deformity. So little about the RA factor I want to tell you. RA factor is nothing but this is an antibody which can be detected. So this is again antibody which is produced, and actually IgM and actually an IgG, it is the RA factor. IgM antibody, and this is the RA factor, right? And anti-CCP or anti-citrulline peptide antibodies, it is a recent advancement. So presence of this positive RA factor. So usually this is a negative predictor. That means if the presence of your yeah, Euler criteria is also used, but usually we use this criteria. Usually in ortho we use this criteria. Euler criteria is also used. That is also used. And this the negative predictor, that means if the RA is negative, you can rule out rheumatoid, but the presence of RA doesn't indicate that this is a rheumatoid. But anti-CCP antibodies, this anti-CCP antibodies are very, very specific. So now the recent advancement is that the anti-CCP antibodies are the diagnostic criteria. So once they are positive, that means the patient is having rheumatoid arthritis. Okay? But RA factor can be used. RA factor, RA factor, if it is not present, I mean if it is negative, you can rule out. To some extent, you can rule out rheumatoid arthritis, right? So that is about the diagnostic criteria. And as yes, RA factor is detected through blood test. So what are the blood tests you advise for the patient? You ask for ESR, CRP, and RA factor. So these are detected by the blood. So these investigations will come positive. So because this is an inflammatory condition, you will have raised ESR and raised CRP and RA factor positive, right? So again, Euler criteria is nothing but there is an usage of your anti-CCP antibodies also. Yeah, it is IgM. So that is about how do you diagnose this rheumatoid arthritis. Okay. Then the deformity. So very, very one of the most important things in rheumatoid arthritis is the deformity. So there are various deformity. So there are various deformities which you have to remember. The most important deformities is in the hand. RA factor fall, right? What is that? RA factor will be positive. Okay. So now the deformities in the hand, the very important deformities is your swan neck deformity, your bottonius deformity. Yeah, if it is rheumatoid arthritis, then RA will be positive. If it is rheumatoid arthritis, then RA will be positive. So what is swan neck deformity? What is bottonius deformity? And again, you can see there are various deviations such as, yeah, usually rheumatoid is characterized by that only. It is usually the extra articular manifestations are also important, but not to very much extent. Just you have to remember them. What are main important in ortho from rheumatoid is the deformities. Deformities is very, very important. And extra articular manifestations, just you have to remember. So they will be in the form of vasculitis, as I've told you, the vasculitis, and that is your Raynaud's phenomenon, right? And then we have discussed about the rheumatic nodules. So on the extensor surfaces, you will see the rheumatic nodules. These are nothing but the depositions, right? These are certain external extra-articular manifestations. Then you have your serositis, like the pleurisy, carditis, and finally they may present with associated with anemia, Felty's syndrome, right? And Sjogren syndrome, right? And then amyloidosis. So these are all the extra articular manifestations. Lung, if serositis, it is pleuritis, right? It is pleuritis and carditis, right? And now, so these are the certain extra articular manifestations, right? And next, coming to the deformity. So we have certain deformities. One important deformity is the swan neck deformity and bottonius deformity in case of hand. And in hand, again, you have Z-shaped deformity, Z-shaped deformity, right? So in swan neck, what happens is swan neck is like this. What you have to remember is FT. So flexion of DIP, right? Flexion of DIP in case of swan. And flexion of PIP in case of bottonius, right? Z deformity is ulnar deviation. So you have this opposite deviations of wrist and the fingers. So that is your Z deformity. That is wrist and your fingers go in opposite direction. So in that you have ulnar deviation of the fingers, ulnar deviation of hand of fingers, right? And in elbow you have mainly the flexion deformity. In elbow, what you see is your flexion deformity in case of elbow, right? And then in case of foot, you see hammer toe, which was given here, hallux valgus and hammer, right? Hallux valgus and hammer toe. And then in knee, you mostly see valgus, varus, or a wind swept deformity. Wind swept deformity, right? Wind swept deformity. Right, so these are the deformities. These are very, very important when you talk about the rheumatoid arthritis. These are very, very important. In ankle, sometimes you can see again your equinus deformity, right? So these are the deformities which you have to remember, right? And knee also, remember there will be a triple deformity again seen in knee. So these are the deformities. So first one would be the swan neck. As I've told you, picture has been given here. So there will be a flexion of the DIP. Will you remember as FT? And then your bottonius deformity is flexion. Then you have elbow, you have just a flexion deformity. And then in the foot, you have hammer toe and hallux valgus. In the knee, you can have a combination of varus and valgus, that is swept of only varus or only valgus. And most importantly, you can have this triple deformity where there is a flexion and posterior subluxation and lateral deviation. The knee, that is the triple deformity of the knee, and then in the ankle you have the equinus deformity. So these are all the deformities which you see in case of your rheumatoid arthritis, right? And these are the extra articular manifestations which we have discussed it. So there are various extra articular manifestations. And now what is more important is the radiology. So in case of radiology, usually what is important, it is bilaterally symmetrical, right? Whatever you see, it is bilaterally symmetrical. And then what is important is the juxta-articular rarefaction. What do you mean by that? So juxta-articular rarefactions is nothing but around the joint. If this is the joint, around the joint there will be this dark color. If you can appreciate, this is the juxta-articular rarefaction. That means there will be some shadow. Uh, yeah, it could be a periarticular osteopenia also, the same thing. It is also called as the periarticular. That means around the joint you can see there is osteo, right? Then one more thing is there is obviously the reduced joint space, right? You have to remember that there would be a reduced joint space, and then you will see lot of bony erosions, and then you see lot of bony default erosions and deformities with juxta-articular or periarticular osteopenia is mainly characteristic of our rheumatoid arthritis, right? Understood? And what is mainly important is your symmetricality. So it is bilaterally symmetrical, periarticular osteopenia, then there would be reduced joint space, bony erosions, usually the marginal erosions, and then there are a lot of deformities which you can see. Understood? These are the radiological manifestations of rheumatoid arthritis. Okay. And then how do you treat it? So we all know this is an inflammatory condition, right? So any inflammatory conditions, we always want to treat it with steroids. So usually we start them with steroids, but now NSAIDs for pain reduction initially, but now what we have is DMARDs, right? What is this DMARDs? This is modifying anti-rheumatic drug. So in this is modifying anti-rheumatic drugs. The first one is the methotrexate. So these are the pharmacological drugs. So methotrexate is one, then HCQ is another one, sulfasalazine. So these three are prominently used, right? And now gold and quinine are not used nowadays, they are obsolete. And then we have the biologics, right? I know, I think you are all better than me in telling what are biologics, okay? Because pharmacology, you deal it in a great detail, right? Yeah. So these are nothing but what are these biologics? So these are your interleukin factors inhibitors or your CD20, rituximab, abatacept, and those certain types of drugs, right? Which can be used as a disease modifying drugs in your rheumatoid arthritis. But what is my concern is about this surgical treatment. So to correct the surgical treatment, so to correct any deformities, usually we go with a process which is synovectomy. So synovectomy is nothing but removal of the entire synovium is present around the joint, because going back to the pathology, the main culprit of entire rheumatoid arthritis is the synovium, right? So the antigens which are produced and which are acting as presenting cells, and now the antibodies are produced. These antibodies will react with the synovium, and this will look like pannus, red looking tissue, which is called as pannus. So to remove this synovium, or this synovium is called synovectomy, which could be a relief to the patient. right? And we will go for soft tissue release. Soft tissue repairs is, so usually there will be tendon ruptures because of the inflammation which is happening. There could be a tendon ruptures. So we go for the soft tissue repair. And finally, if the joint is completely eroded, if the joint is red or completely damaged, and final resort for us is arthroplasty. Arthroplasty means replacement, or arthrodesis. Arthrodesis means fusion. So these are the very important treatments in rheumatoid arthritis, because this is a very disabling disease, right? Pannus is the pathology, the granulation tissue, which is the name given to it. So as we go back to pathology, what happens is there is antigen, and for that antibodies are produced, right? So these antibodies go and fight with the cartilage there, synovium there. So all this will get aggregated. All the inflammatory products will get aggregated into the joint. This is called as pannus, and this is usually a red looking structure. It is a red looking structure called as pannus. No? This is the pathological structure, and this removal of this is called as synovium. It is usually associated with synovium, so we will remove this particular thing. So this is synovectomy, and usually it will go for erosion, so the tendon get ruptured. So this is soft tissue repair, and finally we up with arthroplasty or orthodesis. Arthroplasty is nothing but your joint replacement. Desis is again your joint. The surgical management, when it comes to your medical management, I think medicine people will deal better. So when to use what drug? So there are various drugs we have discussed. So steroids and NSAIDs and the biologics, as we have discussed, can be used, right? Can be used initially, and finally when they land up in all these deformities, we treat it with the surgical procedure, right? Is that clear? Anything you want me to repeat? That is about rheumatoid arthritis. So arthroplasty is nothing but, again, it is a joint replacement surgery. So whenever you go with a knee, for example, in a knee joint, if a joint is completely damaged, so it is usually present with the valgus deformity. Okay, so rheumatoid arthritis, the cartilage is completely damaged. So the last resort for the treatment is arthroplasty. That means replacement. You replace the joint, right? And hip also we go for replacement. But for ankle, usually what we do is arthrodesis. So ankle don't have replacements. It is not very advanced. So in ankle we do arthrodesis. So what is arthrodesis? It is surgical fusion. This is surgical fusion. So we fuse the joint again. That is arthrodesis. Is this clear, guys? We have completed all. And what could be the differential diagnosis of rheumatoid arthritis? So they have asked about the differential diagnosis. So differential diagnosis, usually it will be osteoarthritis, right? So one is SLE, then it could be osteoarthritis, then psoriatic. These are certain differential diagnoses. No, two different surgeries, Samantha, different surgeries. Or once you do replacement, there is nothing you can do. Arthroplasty is replacement. You're entirely replacing the joint. Or in cases where you can't do replacement, you can do arthrodesis. Okay, it is arthroplasty or arthrodesis, not one after the other. Okay, is that clear? That is about rheumatoid. Yeah, SLE, yeah, you can differentiate it. There are various tests which can differentiate SLE. There are various, factors which can differentiate OA and psoriatic. But usually we put this as a differential arthritis. Okay, once we are done with rheumatoid, now we'll discuss about osteoarthritis. So if you understand in great detail about rheumatoid arthritis, this will be a very easy, because here I want to tell you one important thing is this is a degenerative arthritis. What do you mean by degenerative arthritis? Degenerative means wear and tear. That was then inflammatory arthritis. So inflammatory was autoimmune. There were some antibodies which was produced against it, and these antibodies go and act the cartilage. They will involve the synovium. They will result in pannus formation. Now here, this is because of wear and tear. Yes, very good. Aging process. As we use the structure, it is undergoing aging process. This is a degenerative arthritis, usually seen in older population, right? Rheumatoid is seen in younger population, mainly seen in the older population because it is a wear and tear mechanism. Okay, what is the definition of it? So definition, it is a degenerative disorder. Again, arthritis is joint, so degenerative disorder of joint, which is characterized by the wear and tear mechanism, aging process, resulting in again deformity. Right, so that is the definition of osteoarthritis. Right, so that is the definition of. Yes, very good. So one major difference which I want to tell you between osteoarthritis and rheumatoid is, so in rheumatoid arthritis, it is a young female who comes to the OPD and tells you that there is a pain as soon as she wakes up, right? As whereas osteoarthritis, at the end of the day, after repeated usage of the joint, after at the end of the evenings, they tell you that there is a pain. Example, your grandmas, if you go and ask your grandma when you are having pain, they will tell we have at the end of the day after completing entire work, I will have pain. That is osteoarthritis. But usually at the morning, if they have pain and if they are complaining of joint stiffness as they get up, then that is about inflammatory, right? So what is the pathology here? So whenever a wear and tear mechanism has started, so what will happen to the cartilage? So everything starts with cartilage, right? So the cartilage, there will be increase in water content. This is very important. And then there is decrease in the proteoglycan content. So if you go back and read what is, yeah, it is, RA is not usually seen in older age, it is usually seen in middle age. So up to 35 to, by the age of 30, 35, they'll present with RA. If they're presenting after 45, 55, it is usually OA. Okay. So in the cartilage, there will be increase in water content and decrease in the proteoglycan content. So this will cause erosion of the, is also called as version, right? Now the cartilage is damaged, the synovial fluid keeps to subchondral bone. Now it forms the subchondral cyst, right? Once they form subchondral cyst, damage result in subchondral sclerosis, right? Finally, of bone cells, the head will, right? That is the pathology of your uh, osteoarthritis. So where it starts always with the wearing tear in cartilage. So there will be small gaps in the cartilage. The meniscus, usually, medial meniscus, and it is usually weight bearing area. So weight bearing area. That is usually real aspect of knee. Right? What happens is the cartilage. Yeah. So this is because of the overweight. Yeah, overweight and wear and tear mechanism. There is a seepage of cartilage or tear in the cartilage where the synovial fluid seeps into the subchondral bone to tear, and they will form subchondral cyst. And now because of the subchondral cyst, the subchondral bone is exposed. So now there will be sclerosis, and because of that irritation of the periosteum, there will be osteophyte. There will be weakening of the bone, and then there will be deformity. So here what I want to tell you is this OA can be of two types. Primary is again weight bearing wear and tear. Secondary is again whenever there is a trauma or whenever there is an avascular necrosis. Okay, some insult to the joint like perthes, that is all secondary. Primary is usually your and wear and tear mechanism, right? That is about primary and secondary osteoarthritis. So what could be the clinical symptoms? The clinical symptoms mainly, OPD is filled with osteoarthritis. So pain in joint. So patient will present pain in the weight bearing joints. But there will be involvement of both PIP and DIP involved. Right? And what are these nodes? What are the nodes? Well, we have done pediatric fractures no, already last class. Bouchards and Herbidens. So now tell me, Bouchards is seen in where? Herbidens is seen where? BP, HD, right? How do we remember? E, HD, yes. Okay, Kalai is different way, below and above. H is high, Bouchards is below. Okay, for me it was BP and HD. Bouchards is PIP, Herbidens and DIP. Okay, so these are the notes which can be seen. And then usually they present with this deformity. So that is the deformity. Very, very, very. That is about that. And then symptoms. So what do you see? And then signs. So there will be medial joint tenderness, usually in the knee, and you can feel the crepitus. Okay, what is restriction of ends, especially the terminal restrictions. BP is just a mnemonic. Remember that Boucher nodes is in PIP joints and Herbidens is seen in DIP joints. BP is mnemonic. Okay. So there will be terminal restrictions usually of the movements. Then you see the loose bodies which can be observed, and then you feel the crepitus on joint movements, and then there will be medial joint tenderness in case of a knee joint. So those are the clinical signs and symptoms. Then you go for a radiology. So first thing what you see is joint space decrease. So there will be a joint space decrease, usually medial aspect. So it is asymmetrical, right? And then you see subchondral cyst, and we all know how the cysts are formed. Then you see subchondral sclerosis. So the white part on the surface, the subchondral sclerosis, whitish color, right? That is a subchondral sclerosis, and compared to this, you can see the joint space is decreased. Asymmetrical joint space loss. Very good. So asymmetrical joint space loss, subchondral cyst, subchondral sclerosis, and most important is osteophyte. and deform. So what you have to mainly mention is the presence of sclerosis and osteophytes is a characteristic of your OA, right? And finally, what you see is the deformity. So these are the radiology. Usually by X-ray, we can diagnose the OA, right? Osteoarthritis is diagnosed by the X-ray. Now coming to the treatment. Treatment, initially you treat them with NSAIDs, right? To release of pain. And then now have your visco supplementation. So this is again hyaluronic acid inject. So visco supplementation is nothing but hyaluronic acid injection, or you can treat with steroid local injection, right, directly into the joint. So these are intra-articular injections, what I'm talking about, right? So these are non-surgical. Of course, you have to encourage them lifestyle modifications, right? Such as squatting, climbing the stairs, and then quadriceps strengthening, that is physiotherapy, right? These are certain drugs, yes, like PRP injections. Yeah, nowadays PRP is used, but depending upon the stage. So usually stage 1 and stage 2, you can go for PRP, not other than that, right? So there is a lot of buzz about this PRP doing, mix in osteoarthritis treatment, but there is a mixed review of research, you know. So usually what we do is whenever the patient is stage 1 and stage 2, only we will advise them for PRP. Once it is stage 3 and 4, there is no role of PRP. And stage 4, it is nothing but you have to go for total knee, right? And what are the stages? According to the radiology, you'll have the stages. Only symmetric narrowing is there, then that is stage 1. If narrowing plus sclerosis, stage 2. Narrowing, sclerosis, and osteophytes. If the osteophytes, then you will go for stage 3. Deformity, stage 4. So that is how you stage it, and depending upon that, you treat. Fine. And then what is most important for us is your surgical treatment. So again, there are two types. One is osteotomy. I've told it is about varus deformity, right? So you go for a high tibial osteotomy. Fine, high tibial osteotomy. And finally, the most important, that is your total knee. Very, very important. So the examiner looks for, first one, they look for the definition. So you have to explain them, and then you have to explain the pathology, and then you will tell what are the clinical signs and symptoms, then radiology, then the treatment, both surgical and surgical, right? This is how you have to write in the exam. So this is an example of high tibial osteotomy. So you correct it, and this is an angle blade plate which put for correction, and this is the total knee replacement. They will remove the articulating surfaces, the tibia and the femur articulating, removed and replaced by your total knee replacement, your high tibial osteoarthritis, right? So that is it. And complications, what you have to remember for osteoarthritis is, again, they will go to severe deformities where the patient will not be walk. So landing up with deformity, and then because of the deformity, they will be ligament lax, right? Which will lead to instability, right? Then finally, they may lead up to, right? So these are all the complications which they end. It more RA. See, rheumatoid arthritis is very notorious. You have to treat them continuously. RA is okay because RA RA, you have to first treat them with conservative, that is your all your treatment. OA is little easy. RA is little complex. High tibial osteotomy means this proximal tibia. So usually what they say is the knee osteoarthritis is the problem of proximal tibia than your femur. I mean, tibia is more at the danger zone. So what they do is similarly like we have done, right? The osteotomies. So they will cut open. So they want to correct the varus osteotomy. So they will cut here the proximal tibia. They will take the cuts here and then they will try to correct the deformity. So that is your high tibial osteotomy. So which is acting as a correction for the deformity. So what we are worried about mainly the varus or valgus deformity. So the deformity correction is by high tibial osteotomy because nowadays total knee replacements are very high, but the implant or the prosthesis lifetime is only 15 years, right? So if a patient of 35 years or 45 years will come to you with the OA of knee and now you treat with total knee replacement, again they have to go for second replacement, right? So that is why what they do is for age below 50 they will try this high tibial osteotomy, that is for younger patients. Younger patients we go for high tibial osteotomy and older patients we go for total knee replacement. Patellar clunk surgery after TKR. So that is that given for you? That is usually a PG question. Not PGs. So patellar clunk surgery is usually what happens is after the treatment of with the total knee replacement, the tracking will get disturbed and you can hear a clunk. That is the patellar clunk syndrome. Usually mal tracking of the patella after TKR. Right, this maltracking of the patella will happen after your TKR, total knee replacement, when there is a problem in the movement of the patella. Usually there will be lateral displacement of the patella. So this displacement will result in the patellar clunk. Okay, so that is about your osteoarthritis. Okay, is that clear, guys? Anything you want me to tell you? So that's it. This is a surgical treatment and the conservative treatment. And mainly what you have to remember is the pathology. So pathology is what they look for, and then your uh, radiological symptoms. See, hand OA, you can mainly write about your turbidence nodes and your Boucher's node. That would be enough. Atypical OA, hand OA is not required for you, but this is the erosive arthritis, what they talk about, the gulving deformity. Atypical OA or hand OA is that. Okay. So usually you don't see erosions in case of arthritis, right? So it's not arthritis. Erosions, it is called as ATPA or your delving. So that's it for today. And patellar clunk surgery, as I've told you, that is after TKR. If the patient hurts this, by movement on extension, they heard this patellar uh, sounds, a small they heard this, right? It is because of some nodules or malposition, the prosthesis, cracking of patella that result in the. So this is how you download the app and explore Farre series, because every subject has Farre right from year to fourth year. And now you can go to the app, download the PW app. There you have the Farre series, and there you can access for any subject, right? And that's it for today. Hope you all have understood, enjoyed. Any queries you want to ask or anything? It. Then that's it for today. Meet you all again in the next lecture, where we will with infections, oncology, or small topics such as influence, all the soft. So let us meet again. Anything you have, you can DM on Insta, or you can follow Insta PW MedEd. All tracking of patella, not tibia. Not required at your level. And Dr. Alekhya Ortho. This is my Instagram ID. You can DM any query you have. Okay. So that Samantha, what we were talking about is mal tracking of patella after TKR surgery, not tibia. So whenever you flex and extend, no, the patella keeps moving. So this patellar clunk syndrome is whenever you extend, you can hear a different sound. That is called clunk syndrome. And that is because of various reasons. You can the processes, fibrous nodules, or there's some sort of there between. That is called, and sometimes because of the mal tracking of. So that is called patellar clunk. And atypical or hand OA is not very important, but this is a type of erosive osteoarthritis, and you can valving. Okay. And any other things you can ask on PW MedEd and Dr. Alekhya Ortho Insta. So download the app and access the Farre series. And now we are also coming up with MedEd clinics as well. So there are various checks clinicals is what has been taught. So you can access all those on the PW MedEd. Fine, guys. Thank you so much. It has been all wonderful. Kalai and Samantha and Yush. Thank you all so much. Good night. Meet you all in the next class. Bye.